Hello, am I audible? Tag team, am I audible? Professor Arora, am I audible?
Yes, doctor, we can hear you. Dr. Satpathy, would you like to test your slides?
Hello, Shefali.
Good evening, sir.
Yeah. Hope all is well.
All good, sir.
Already.
Already. I've spoken personally to Dr. Sood as well.
Yeah. Dr. Sood is ready now.
Anji?
Dr. Sood is ready.
He's ready. Absolutely.
Ashish, good morning. This is Sanjay.
Hi, good morning, Dr. Sanjay. How are you?
Good, good. Wish you a very good session today.
Thank you. Thank you.
Dr. Ashish, I've been trying Dr. Bhupendra's number from Nepal. काफी देर से सिर्फ उनका busy जा रहा है. Call waiting आ रही है. I've sent him a message and an email as well. बाकी Dr. Hasnain से मेरी बात हो गई है from Pakistan.
Okay.
And he'll be joining in. And Dr. Ananta is also confirmed. Rest everyone is confirmed
Okay.
for the first session.
Okay.
Good evening.
Good evening, Dr. Jayanti. How are you?
I'm audible, Dr.
Yes, ma'am, you are.
It's clear.
Yes. If you can speak a little louder, closer to the mic, it would be better.
I've got a headpiece. Is it okay now? Better?
Slightly better, ma'am.
I'll
A
speak
little
a
loud.
little louder. Louder
Yes.
now. Okay.
Yes, ma'am. Thank you. Good evening, Dr. Anand.
Good evening, ma'am. How are you?
I'm very well, thank you, sir. How are you?
I'm fine. Can you hear me?
Loud and clear.
Okay.
Good evening, Dr. Hasnain.
Good evening, and greetings from Pakistan, from Karachi.
Same to you from India, sir. Thank you. Good evening, Dr. Ghosh.
Good evening, sir. Dr. Anand, sir.
Good evening, ma'am. How are you?
I'm fine, sir. How are we starting? You'll introduce, or shall I introduce Ajit and then the
Whatever you
panelists?
say, whatever you say.
I just start off and ask Dr. Ajit to give his lecture, and then we take up the panelists.
Okay, ma'am.
Good evening, everyone.
Good evening,
Hello.
Dr. Ashish.
Hi, Ashish. How are you?
I'm good, sir. Good evening, Dr. Hasnain.
Good evening, Ashish. Past memories, we have been interacting in international conferences and in India, but now this COVID business has really limited our interactions in a big way. Don't know how long it will continue, but hopefully wish to and hope to meet up
soon.
again.
Yeah. Dr. Arora, you're muted. You're saying something.
Yeah, good day to everybody.
Good evening. Good
Dr.
evening.
Hasnan, Dr. Anand, Dr. Jayanti, Ashish. Who else is there? Dr. Jayant Ghosh, Shri Dr. Ajit, I cannot see. I'm sure there are some advantages also of e-meeting. See, your travel is gone, you're waiting. I remember Dr. Anand, we will meet every weekend on Indira Gandhi International Airport. People will be flying in different directions and Monday back on the same platform. So out of the 52 weekends, I think Dr. Anand must have been traveling on 42 weekends. So that must be a big welcome relief, Dr. Anand.
Even the webinars have become now a
That's
nuisance.
right. That fatigue has set in. It's more of a back fatigue now.
Too many webinars.
Yeah, advantage is if you don't like to attend a webinar, you have a good choice of not going, not attending, or pretend to be attending. Unlike in the physical meeting, you have to be there by force. If
No,
not
but-
by choice.
Hi, everybody. Good evening. I just joined early.
Hello.
Hi, Dr. Mishra, how are you?
Hi, sir. Fine, thank you. But even there, you can pretend to be listening to the speakers. And
Yeah, we can sleep.
but the problem is without physical meeting, it's these are more tiring, and you don't get that feel.
I know the physical meeting had their own
And-
charm.
Yes,
You
and then
could
meeting
be
friends,
off- You
seeing
could
you
be
face to
off
face.
from your work for about 1 or 2 days.
And we
I
could
know.
also hear singing of Dr. S.P. Mishra.
That's
Dr.
a pain,
Mishra,
but
if it was to be physical meeting, you were scheduled to be singing today. Please remember that.
yes, that's so. I can sing today. Don't worry.
And I've had probably one of the most enjoyable time with Dr. Mishra in one of the physical meetings. And that is what one does miss.
What was that?
That was Indore.
Indore.
We were sitting together, but singing for a long time. And then again, API Hyderabad.
Hyderabad, yes.
We were in the same room there.
ISP.
Mishra Saab will not have his orchestra today to support his song.
He can
He
make his
doesn't
own
need orchestra.
orchestra.
He doesn't need. He can sing.
Dr. Hasnan, Kishore Kumar never needed a musical director.
I have the largest
Would you
collection
agree
of.
with that? If Kishore Kumar was singing, you don't need any instrument, you don't need any tabla, you need any guitar. His voice was good enough, so we have a replacement for him.
No,
That
but
is
someone
you.
said that Mishra ji is Muhammad Rafi of doctors. He's the ultimate.
Is Muhammad Rafi, is Kishore Kumar, he is
And
Talat
Mukesh.
Mahmood, he is
And
everyone.
Mukesh, and Mukesh also.
And Mukesh also.
And you can
Yes.
you can see MS Subbulakshmi smiling over there.
Dr. Hasnan, would you recall that we had a trio of singers, which were the legends,
Ji.
Mukesh and Muhammad Rafi and Kishore Kumar. We have never
Yes.
found a replacement.
Yes.
No, they were much.
Maybe Dr. SPM is the avatar of all three trios.
There were many more. Talat Mahmood, Manna Day, Hemant Kumar.
But then all these three were, I think at a much higher platter than the rest
No
of them.
doubt. But Talat had also a niche for himself. Hemant Kumar also. Manna Day. If nobody can sing a song, it was given to Manna Day.
You have to start in 1 minute.
I'm going off.
Shefali ji, are we ready?
Good evening, Ajit. How are you?
Yes, sir, we are ready. In just a few seconds, I'll let you know.
So we are going to have a lot of pakoras of gut microbiome from Ajit Sood. Hi, Monica. Hi, Anand. Have you joined? Deepak?
Yes, sir. I'm
You-
here.
Among the panelists who all are there,
Dr. Shrestha is there, Dr. Srihari is there, and Dr.
Okay.
Jain, all are there.
Dr. Basnet has not come.
Dr. Anand, I have a request to make. We have a uncanny bad habit of exceeding the time. Maybe at the heart of the heart, we want to push in more knowledge, but then we are criticized repeatedly. Somehow we are not able to mend those fences. So maybe request you to please see to it that we remain to the constraints of the time.
Sure.
The person who exceeds time is you only. You start asking questions after the time is up.
Okay, no more question today. Done.
Okay.
Thank
start.
you. I will thank you.
So I can ask you this question after the conference is over. You have to answer.
Yes.
You can ask them before the time up is there.
We'll meet in person that time.
Okay.
Dr. Arora, start.
Okay. Good day to everybody. Good morning, good afternoon, and good evening to all those joining from different parts of the globe. Welcome to our 20th edition of the annual Hepato-Biliary meeting, which we have renamed as Clinics in Hepato-Biliary Disorders. Thanks to all of you for your constant encouragement to have a good academic forum on which we discuss the common day-to-day hepatology and gastroenterology topics. Our meeting had started yesterday, and we had an excellent 3-hour session in which more than 1,800 delegates attended the meet. Today, we have the bread and butter of gastroenterology. And what we are going to discuss today are the advances in the luminal gastroenterology. As there has been a swathe of information amongst the sea of knowledge and ocean of knowledge, which has perpetuated over the last 3 years. So we have a galaxy of the speakers, moderators, and chairpersons who are going to fish out the best amongst the published literature in the field of 5 different topics which we have selected today. These include gut microbiome in health and disease, advances in the functional bowel disease, newer molecules and inflammatory bowel disease, the IgG4 related GI tract diseases, including hepatobiliary involvement, and finally, the diagnosis and management of something common and more often neglected disease called hiatus hernia, its diagnosis and the current approach to management. We are lucky to have excellent speakers, moderator, and chairperson who are going to take us through this journey of academic feast. With that, I'll hand it over to Ashish to carry forward the proceedings.
Thank you, Dr. Arora. So without wasting much time, I would like to start the first session, that is the gut microbiome role in health and diseases. And for this, I would like to invite our moderators, that is Dr. Jayanti Venkatraman and Dr. A.C. Anand. Both of them need no introduction. Dr. Jayanti is presently Professor and Head of Department of Hepatology at Sri Ramchandra Institute of Higher Education and Research at Chennai. And Dr. A.C. Anand is a veteran surgeon, Vice Admiral, Professor and Head of Department of Gastroenterology and Hepatology at Kalinga Institute of Medical Sciences, Bhubaneswar. So I hand over to Dr. Jayanti and Dr. A.C. Anand. Over to you, sir.
Good evening, everyone. We start today's evening program on recent advances in luminal gastroenterology. And our first speaker is Professor Ajit Sood. He's Professor and Head Department of Gastroenterology at Dayanand Medical College and Hospital, Ludhiana. He's well known for his major contributions in various aspects of inflammatory bowel disease. So I request Dr. Ajit to please take over and start the proceedings.
Thank you.
Dr. Ajit has started looking more distinguished with the white hair.
You could catch it. Thank you. Thank you so much. Thank you, Jayanti, and thank you, Dr. Anil, for the invite. I'm going to take up the topic of gut microbiome in health and disease. There are 2 terms which are used. They are not those synonymous, microbiome and microbiota. Microbiota actually denotes the organisms which are there, while microbiome means that they're there, of course, and it includes that what all functions are they doing there. So microbiota means that who all are there, and microbiome means what are they doing there. So this is the minor difference. These 2 terms are commonly used, but they're not exactly the same. I start with the year 2017. A book became available on Earth's essential life forms, and Earth was described as planet of microbes. I quote the author that we are living in an era of unprecedented scientific knowledge about the origins of life on Earth. But if we want to know to have the real big picture, we have to start small, very small. That's because the real heroes of the story of life on Earth are microbes. A year later, the news was that the astronauts identify unknown microbes in the space for the first time. 3 years later, the organism Methylobacterium could also be isolated from the International Space Station for the first time. And a step further, bacteria could help in growth of plants in the space station. So what started as a planet of microbes is actually a universe of microbes. Not only that, there are two universes. These two pictures look somewhat similar. The first picture on the left is a picture of a galaxy from NASA, and the second picture is an electron microscope picture of microbes in a gut. So they look somewhat similar. They're different universe. Microbes hold the key not only for human health, but for different functions like ecological functionality, nutrient cycling, climate change, biodegradation, and of course health. We are going to discuss issue of health today. I just wanted to share with you that it's not only health, but there are other aspects for which microbes are equally important. Hippocrates could make out that gut malfunction is the root of all evil. And we realize now that microbiome inside the gut or microbiome is related to poor gut function. So this concept was there was known to Hippocrates as early as 400 BC. Now, looking at this figure, if you look at the number of publications which started in 1975, for 10 years or 25 years, there are very few publications. Since 2010, the last decade, there's a steep rise in the number of publications, highlighting that there is massive interest in this microbial science now. So much so that this was there on the front page of Nature, and it is described as the other genome. This is based on the facts that there are 100 trillion microorganisms inside our gut. And the microbial genome is at least 100 times more than that of human genes. And these produce thousands of metabolites and can really be considered as an independent organ system inside our body. Now, most of the microbes inside our gut are strict anaerobes, followed by facultative anaerobes and aerobes. Now, when we go from proximal to the distal part of the digestive tract, there is a change in the number and the type of organisms. In the stomach, it's mainly the lactobacilli, streptococcus, and gram-positive kind of organisms, besides Helicobacter. And as we move distally, the number increased and the organisms become more anaerobes. Even in a given segment, the number and the type of organisms differ in the lumen, in the mucous layer, and the epithelial lining. When we talk of different phyla, there are at least 25 phyla inside our gut, of which bacteroidetes, firmicutes, proteobacteria, actinobacteria, fusobacteria, varicomicrobia, and cyanobacteria. These are the main 7 phyla. Bacteroidetes and firmicutes are anti-inflammatory, while proteobacteria and actinobacteria are considered, and fusobacterium are considered pro-inflammatory. These 4 bacteroidetes, firmicutes, proteobacteria, and actinobacteria constitutes more than 90% of the total microorganisms. Of course, besides bacteria, there are fungi, algae, archaea, and viruses. But we don't have much information on the functionality of these organisms at the moment. So we talk mainly of bacteria as of now. Now, how to define healthy gut microbiota? When we Google it, the answer is sorry, something has gone wrong because there's no definition is there for healthy gut microbe. So what it is? What is the microbial health? These are the components that the functional core is important. What happens in the first year of our life, immediately after birth, with the first drop of meconium, the first inoculum, the vaginal bacteria, they gain access to our gut. And these bacteria are basically lactobacilli. So it depends whether the birth has been with the normal vaginal delivery or with the C-section. If it is through the vaginal route, the organisms which are the first one to grow inside the gut are likely to be lactobacilli, while C-section is supposedly a cleaner environment and the organisms may be likely to be Clostridium perfringens. So there is a difference. It's a core group of organisms which matters, and the functional core is preserved because of redundancy. Even if there is a small decline, but it is good enough to be a persistent. Other point which is very important to understand is that it's the community ecology. It is not that organism A, B, or C will matter. Individual organisms number will not matter. As I mentioned earlier, it's the functional core which is important, and that relates to the diversity. That the number and the diversity are the two important things. Resistance to change. If we give antibiotics or any drug which changes the organisms or which kills some of the bacteria, the resistance means it resists the change and it reverts back to the original within a few days. Like after antibiotics, it comes back to the same within 2 to 10 weeks or so. Resilience, it has a capacity to bounce back to normal. And stability, which is again related to redundancy. So these are the constituents which suggest a healthy microbial community. The main functions of the microbiota inside are digestion, metabolism, maintenance of immune system, not only maturation of the immune system, but constant education of the immune system, epithelial homeostasis, gut function maturation, the resistance to organisms are some of the important functions, and these functions relate to intake of items like dietary fiber, starches, healthy lifestyle. If a lifestyle becomes unhealthy and there is exposure to antibiotics or a diet like high fat diet, high meat diet, that shifts the balance from symbionts to pathobionts, and that culminates in various diseases which are not confined to the GIT but outside the GIT as well. And the main diseases we all know what has been related to the microbiome are IBD and C. diff infection, metabolic syndrome, obesity, diabetes, fatty liver, and neurological diseases like autism, Parkinsonism. Now, pathogenesis, what happens when the commensal microbiota are there inside the gut? They produce adequate amounts of short-chain fatty acids, mainly butyrates, and butyrates are important for the nutrition of the enterocytes. Once adequate concentration or amounts of short-chain fatty acids are there, the production of antimicrobial peptides and mucin is adequate. That helps in maintaining the integrity of the gut barrier function, and it remains impermeable. What happens when there is a dysbiosis as shown on the right hand of the picture? The short-chain fatty acid producers they decrease in number. The hydrogen sulfide producers may increase in number. This results in decrease in antimicrobial peptides and mucin production, resulting in disruption of the epithelial lining, leading on to bacterial penetration, which leads to dysregulated immune system, and pro-inflammatory cytokines can result in chronic inflammation, leading on to disease like IBD. About the liver disease, again, intestinal microbiome has a role. If because of some factors, the butyrates, as I've been saying earlier, they decrease in amount, the butyrate butyrate producers are less, and there is impaired bile acid signaling, resulting in increased permeability of the gut, leading on to endotoxemia and leading on to decreased VLDL secretion, can ultimately result in various liver diseases, fatty liver, alcohol-related liver disease, or PBC and PSC, and cirrhosis and HE, not related to pathogenesis of cirrhosis, but mainly HE. Neurological diseases, again, relationship with Parkinsonism, autism is well established or well known. It may happen, I'll say, through alpha synuclein transport or excessive aggregation in the neurons. So what happens ultimately, there's increased production of pro-inflammatory cytokines, which result in various intestinal, liver, or neurological diseases. And there's a shared microbial mechanisms. The first thing which can happen is that the microbiota composition changes, the diversity may decrease, leads to changes in the microbial function, short-chain fatty acid producers may decrease, dysbiosis leads to dysregulated immune system and inflammation and structural damage. So this is how it can ultimately culminate in various diseases in different organs in the body. For precision medicine, we have to know genome of a person, epigenome, transcriptome, proteome, and metabolome. These are the known facts. And microbiome, of course, which is the latest addition. If it is in dysbiosis, the disease is there. If we can correct this dysbiosis and lead to homeostasis, it can be used as a therapeutic tool. Now, how can we manipulate the gut microbiota? There are different ways: diet, antibiotics, probiotics, and fecal microbiome transfer. I'll start with diet. I'll take up inflammatory bowel disease as a prototype example of the diseases. Now, Cochrane Library studied the effect of diet as a therapy for inflammatory bowel disease. The effects of dietary intervention on both are uncertain. The evidence is not robust at the moment, and hence no firm conclusions regarding the benefits and harms of dietary intervention in Crohn's or UC can be drawn at this moment. But there is a need for consensus on the composition of dietary intervention in IBD, and more studies are required. Important is more studies. Now, the drawbacks with the dietary studies are that most of the studies have been cross-sectional and they have been focused on one individual dietary item. While diet is not all about particular nutrients, it's about diet as a whole, a dietary pattern, our feeding, our diet habits, and other confounding factors. It's likely that the future studies will remove these drawbacks and there may be more answers about the role of diet. Probiotics, this is a study from our group. We use VSL3 for induction of remission in patients with mild to moderately active ulcerative colitis. And we did find promising results with high concentration of VSL3 as far as achievement of remission is concerned, response is concerned, and even mucosal healing is concerned. There was benefit compared to placebo. Now, this meta-analysis comprising of 7 studies on use of probiotics in IBD, and this forest plot shows that the response is close to 1. So it's very equivocal. We can't say that probiotics have unequivocal evidence of beneficial effects in IBD at the moment. Coming to antibiotics, which have been tried in both Crohn's and ulcerative colitis. In Crohn's, the Cochrane Library observations are that the evidence at the moment is not very strong. It's very modest. And in ulcerative colitis again, the use of oral antibiotics in the setting of non-severe ulcerative colitis could have some benefit in clinical response, but not remission. But at the moment, for both ulcerative colitis and Crohn's, the evidence is really lacking, except for a few situations in Crohn's like perianal fistula. FMT in IBD, of the 4 landmark RCTs on use of FMT in active ulcerative colitis for induction of remission, 3 trials were positive. The 3 trials results were in favor of FMT compared to placebo. These 4 trials varied a lot in the route of administration and the protocols. The first plot shows convincingly that FMT scores over placebo. Now, this is quite different what we saw in probiotics. Our own experience, we have used FMT in a select group of patients, that is steroid-dependent ulcerative colitis, and we have used FMT to study the maintenance therapy. Now, FMT, as I've been saying, that whatever changes we can whatever manipulations we do to the gut microbiota is not sustainable. So the question was whether we need a long-term therapy for sustenance of the beneficial effects or not. And this is what was documented by our study, that a long-term maintenance therapy is required for ulcerative colitis. For liver disease, again, antibiotics have been used, but we keep it in mind that antibiotics can also be hepatotoxic. Regarding FMT, in alcoholic hepatitis, the results are quite conflicting. Hepatic encephalopathy, there may be some beneficial effects, but the studies are very, very limited. In Parkinson's disease, I am not in a position to say much, but we have one patient of Parkinson's disease who comes to us regularly, and he is with us for 2 years, and he really is very impressed with FMT. He says that his number of drugs is reduced to 25%. So there are different results with different targets. So what is the reason? So at least we are consistently inconsistent when it comes to the response rates to diet, manipulations, antibiotics, probiotics, and FMT. Now, because this happens because there are so many confounding factors which can influence these therapies. And one of the reasons what we forget when we evaluate these therapies are that the diet and lifestyle, I can say about FMT, that any study on use of FMT for any disease, we need to keep it in mind that the diet and lifestyle of both recipient as well as donor is very important. So diet is not just about eating, it's about food choices, the pattern of eating and the lifestyle, and a habitual diet matters. It's not a change in diet over a few days or weeks matter. It is a habitual diet what defines a gut microbiota, and microbiota will lead to production of various metabolites. Today we talk of microbiota. Tomorrow we may not really focus only on microbiota, but attention may shift to metabolites. And once the metabolites are there, then they decide what kind of health status a person is going to have. So a holistic approach is that when we want to manipulate our gut microbiome, by any means, FMT or probiotics or phage therapy, keep it in mind the microbiota and the metabolites both, and don't forget diet and lifestyle of both recipient and the donor. That will result in more sustained beneficial effects. So microbial science is evolving rapidly, looks promising but needs to deliver. Personal medicine can be possible, but healthy lifestyle is the key to good health if we can sustain a good, healthy microbiome inside. Thank you.
Thank you, Professor Anand. Thank you, Professor Sood, for that wonderful coverage of this topic. Over to Dr. Anand, please.
Very much for that excellent oration. You have made a very complex topic look very simple by your lucid description. I'll request you to stay online for some questions. And we have a very distinguished panel here for you. One is Dr. Anant Shrestha. He is the General Secretary of Liver Foundation, Nepal, and Secretary of Nepalese Association for the Study of Liver. He is here. And second is Dr. Bhupendra Basnath. He is the Senior Consultant Gastroenterology at Bir Hospital, Kathmandu, Nepal. Third is Dr. Hasnain Ali Shah. He is Professor of Medicine and Gastroenterology at Aga Khan University Hospital, Karachi. We have Dr. Jayant Kumar Ghosh, who is a Senior Consultant in Gastroenterology at Ranchi and a very famous gastroenterologist in this area. And then we have Dr. Srihari Anikhindi. He is a Senior Consultant in Gastroenterology at Sir Gangaram Hospital, along with Dr. Anil Arora. So I'll request all the panelists to think about a question. And I'll start the ball rolling by asking you one question. That if you look at the genetic material in our body, the human genetic material is outnumbered by the microbial genetic material by about 2,000 to 1. That means 2,000 times higher genetic material of microbes is with us. So do you think many of the genetic diseases we can manipulate by manipulating the microbiota?
Definitely. Now, when we talk of genetics, I mean, the genetics and epigenetics are there. Now, when I can talk about a specific disease. Now, GARD15 in IBD has an important role, and GARD15 mutation is known to increase the risk of Crohn's disease. Now, this genetic mutation is related to the bacterial sensing gene. Now, this again relates to various organisms inside the gut. Now, the kind of microbiome which grows inside a body is again decided by the genetics of a person. Now, these are, two ways. At the moment, we really can't say specifically that which microorganisms. And as I've been saying again and again, it's not going to be just 1 or 2 or 3 microorganisms. It's going to be the community and the metabolites which is going to decide.
Okay, I'll just take 1 or 2 questions from the chat box. Dr. Ashish Kumar has asked, what is the role of fungal and viral microbiome in health, or are they always pathogenic?
No, all fungi are not pathogenic. Now the interest is moving on to study of fungome. At the moment, we don't have really many RCTs based on fungome, but I'm sure in future, we are likely to see more of RCTs based on fungome. And there's one study from PGI where they have shown that Candida may be one of the reasons for precipitation of relapse in ulcerative colitis. So fungus has an important role to play. And as I mentioned that the archaeviruses and fungi at the moment don't have evidence, good enough evidence to really talk of at the moment. But in future, I do expect.
A similar question is from Dr. S.P. Mishra. He says, do we know about the interaction of bacteria with fungus, amoeba, and viruses, and maybe other things in the microbiota? Are there good fungi, good viruses, good bacteriophages too?
Yes, I mean, phage therapy is one of the therapies, and all the organisms are interdependent and interlinked. Their functions are definitely interlinked. At this moment, we don't have adequate information about other organisms besides bacteria.
Dr. Shrestha, you have a question?
Dr. Shrestha, you have a question?
Yeah, most of the diseases that we've discussed so far, maybe IBD, C. diff, or even alcoholic hepatitis, and most of these diseases are multifactorial, So there are definite genetic component as well, there are environmental component as well. And another thing is microbiome. So do you think that microbiome is just a part of the, the whole disease process. So for example, somebody with alcoholic hepatitis who's been consuming alcohol for maybe about 10 years, it is expected that the microbial change will be there in the gut. Now this patient develops alcoholic hepatitis. You can directly correlate or develop a causal relationship between the microbiome and the disease process, because alcohol can be affecting the microbiome, and alcohol can also be affecting the liver disease itself. So do you think that like they could be interlinked, or it could be a separate thing, or there could be a causal relationship between the microbiome and the disease?
Right, very, very important question. At the moment, what we have evidence is an association. We don't have evidence at the moment to say definitely these are the causative organisms. Associations are strong enough at the moment. Now, you said that about alcohol and other things. I will again come to the same point that diet and microbiome individually will not be the final reason. Now, I give you an example that in diet, we say that red meat, high sugar is bad for IBD. They're more, pro-inflammatory, while fiber is anti-inflammatory. Now, if a person takes high fat and high meat intake with very low fiber, he's more likely. But if he compensates by taking high fiber as well, now how much is the contribution as a protective factor by high fiber to counter the pro-inflammatory actions of red meat and high sugar? We really don't have answers to this at the moment. That's why it's a holistic approach. What matters?
There are a couple of more questions in the chat box. One is alcohol intake okay for the FMT donor in IBD?
In moderation, yes.
Okay. And Dr. Anil Arora wants to know, why do we jump to therapy with microbiome when we don't even know their function properly? Are we not jumping the gun?
Not really. There have been studies. I'm sorry, I've been talking more of IBD because this is the area I work more.
So you have a lot of work on use of microbiota in ulcerative colitis.
Yes.
And we are aware of that.
So you'll excuse me for focusing on IBD. Like firmicutes, spores have been used for ulcerative colitis. This is the first microbial-based therapy, single microbial-based therapy, and have been found to be useful in remission, in achieving remission in ulcerative colitis. So definitely it's time to move on to therapy, though gradually, step by step.
Dr. Srihari,
what do you have to say about the FMT in the time of Corona?
Our program is practically to a halt for last 1.5 years. In last, I think 1.5 years, we have done 6 or 7 FMT sessions. Right? Earlier on, we were doing around 20 to 30 sessions a month. So now it's only the patients who are insisting that they benefited so much from FMT previously, and now they're not responding to other therapies we are doing. But otherwise, we are not promoting. We are not recommending.
Let me ask my other co-panelists. Dr. Bhupendra Basnath, would you like to make a comment or a question? Okay, he's not.
Can I ask the questions, ma'am? So,
yeah, please do.
Yeah, sir. So when we talk about microbiome, we frequently talk about the various phyla that are involved, like firmicutes and Bacteroidetes. Is it the entire phyla which is responsible for these functions, or are these individual species, so many species which are a part of this phyla? Do individual species also matter? Because nowadays there are so many organizations who have been giving you these personalized microbiome reports, Gut Speaks and all. So how do we interpret a report? Do we really have some clinically relevant information when a patient comes to us with his or her microbiome? Can it be utilized? Do we look at the phyla? Do we look at individual species? How do we interpret a report?
Yes, very, very important question. That it's not at the phyla only what matters. Species or even subspecies level matter. Now, there are few examples like for Crohn's, we know organisms like Faecalibacterium is anti-inflammatory. Deficiency of Calypbacterium increases the risk of Crohn's disease. Fusobacterium, E. coli, when they increase in number, we know that they are pro-inflammatory. So they can result in IBD. When we look at the RCTs where they have studied microbiota, all the RCTs or all the studies are showing divergent results. In our own study on FMT, we have identified bifidobacterium or lactobacilli abundance in responders to FMT therapy. So one of the things which I showed was that results have been very, very inconsistent so far. But your point is right that it may not be phyla, it may be at different levels. But at the moment, really, when we talk broadly, we talk broadly of phyla, like firmicutes like Clostridium 14 and 4 species, they are actually anti-inflammatory.
Dr. Shah?
Hasnan, would you like to make a comment or a question? Would you like to ask a question?
Yes, certainly. First of all, it was lovely listening to Dr. Ajit Sood.
I'll request you to be short
long
because we have
time.
only 50 minutes left.
Yes. My question is that I think as one of your slides showed that most of the research, the knowledge have been achieved in the last 10 years. And very little from the Indo-Pak subcontinent. I have this feeling that a lot will depend on the gut flora of the region. Pakistani food is different. India is a huge territory. Nepal, Bangladesh, okay, agreed, they're mostly fiber-containing foods. But again, there are differences, major differences. And how these microbiota will behave depends largely on that. Even people have looked at the longevity, quality of life by treating these, but that is on different sets of populations. So what I want to stress here is that we want to have multi-center trials from different parts of the subcontinent to ascertain which a probiotic or prebiotic will be useful in a particular disease.
Thank you for your comments, sir. Thank you. Dr. Jayant?
That's it.
I agree with Dr. Khan's comment. I think it's right.
Dr. Ajit, we'll just take Dr. Jayant's question.
Sorry, yes.
Dr. Jayant?
Dr. Jayant Kumar Ghosh, would you like to make a comment or would you like to ask a question?
Unmute, please. Unmute.
Okay, while he's unmuting himself, there are a lot of other questions in the chat box. Gut decontamination with antibiotic, what is the role in treatment in the sepsis? This is Dr. Ajay Gupta.
I think Dr. Jayant has unmuted. Dr. Jayant?
Yes, sir. Yes, sir. So my question is that in 2006, we have published one study in tropical pediatrics regarding the premature babies, where we found that using this probiotics with breast milk, express breast milk, it can help the, necrotizing enterocolitis. And also another conclusion was that the feeding in these premature babies, they were much more tolerated when these prebiotics were given along with express breast milk. So can we also supplement this probiotic in critically ill patients in ICU when we are starting rice tube feeding in these patients? Is there any beneficial effect?
Yes, breastfeeding, breast milk is very influential, has a strong influence on development of microbiota in the early months of life. The major changes in the microflora occurs after withdrawal of breastfeeding. Right, so it depends. The microbiome development actually relates to breastfeed or provision of a formula feed. So breastfeed has a strong influence on development or shaping up of the composition of microbiome in the initial months of life. And we know that microbiome or microbiome science, microbiome therapy can fight with the multi-drug resistant organisms.
There are quite a few more questions in the chat box, but time is finished and Dr. Arora has given me very strict instructions that I must finish on time. So I will thank Dr. Ajit Sood for an excellent talk, very lucid, making a very complex subject very simple. And my co-moderator, Dr. Jayanti, for excellent moderation, and my co-panelists who have asked very intelligent questions, and for Dr. Sood again for giving excellent answers. Thank you very much, and over back to you, Dr. Arora, right on time.
Thank you. Thank you.
Thank you, Dr. Anand, and thank you, Dr. Jayanti. So we move on to the next session, that is newer molecules for IBD. And for this session, I would like to invite our moderators, Dr. S.P. Mishra and Dr. B.D. Goswami. Dr. S.P. Mishra is a professor and head Department of Gastroenterology at Motilal Nehru Medical College, Allahabad. And Dr. B.D. Goswami is the head of gastroenterology at Dispur Hospital, Guwahati. So over to you, Dr. Mishra and Dr. Goswami.
Good evening. Good evening, all the delegates. We have got the next session on the newer molecules on IBD. I, with my co-moderator, Dr. S.P. Mishra, we welcome all of you for this session. And we know the IBD management is a very difficult issue, complex issue, because whole pathogenesis is a complex one. So with this, we have got the speaker, Dr. Binit Ahuja. He does not need any exceptional introduction because he is one of the authority. He is the professor of gastroenterology at AIIMS, New Delhi. We have got the expert panel, Mr. Ajit Kanal from Kathmandu, Monica Jain from New Delhi. We have got Saurabh Kedia again from AIIMS, New Delhi. We have got Sudhanshu Patwari from Gujarat, Ahmedabad. And also we have got Munish K. Sosdeva. So let us listen to Dr. Binit Ahuja on the molecules, and after that it will be followed by the discussion and the moderation with the panelists. Over to you, Dr. Ahuja.
Thank you very much, Dr. Goswami. Are my slides visible, please?
Yes, yes.
Yes, they are. Okay. First of all, grateful to Dr. Arora for inviting me for this talk. I'm supposed to talk about newer drugs and IBD. However, I thought about that I'll talk about newer drugs and IBD in our country, something which is much, much more relevant for us. When we talk about new things, you see that every year we are having breathtaking advances which are taking place. In fact, when we look at the field of physics, we find that muon, which is a tiny particle, which is supposed to be slightly more denser than electron, that seems to be breaking all known laws of physics. It's recent work which has come up showed that it is probably hinting at a fifth fundamental force of universe. We have already been always taught about that the universe, the solar system, it had 9 planets, and people said it had 8 planets. And finally, it was decided that Pluto should not be a planet. And so this year came up some data, very clear-cut data, which showed that there is another planet which is there subsequently after Neptune, and that is possibly the 9th planet rather than Pluto. So there are breathtaking advances which are taking place in every field. In the field of IBD, we had TNF-alpha, and we had the TNF-alpha monoclonal antibody, and subsequently, initially infliximab, and thereafter we had the fully human form, and that was the adalimumab. And at that time, it was thought that this would revolutionize the field totally for IBD, and this would be actually the epitome in terms of all kind of advances which have taken. But let's see what has happened now. Subsequently, it was seen that you wanted to block the lymphocytes from entering into lamina propria, which is the site of inflammation. So on lymphocytes, you have alpha-4 beta-7 receptors. They interact with MATCAM1 receptors, which are there on the endothelium wall. And once they interact, they're able to go through the endothelial wall and go to the lamina propria. And came up vedolizumab, which is an alpha-4 beta-7 inhibitor. It's a monoclonal antibody. The moment it blocks alpha-4 beta-7, the lymphocytes are not able to interact with MATCAM, and they are not able to move to the lamina propria.
Vinit, can you come closer to your laptop, please?
Okay, sir. Can we target multiple cytokines? So we have the oral small molecules. And remember that none of the currently approved biological therapies, they target the intracellular component of cytokine signaling pathway. Cytokine signaling pathway is very important because it is a common route for most cytokines. IL-2, IL-6, IL-12, any cytokine, once it goes to a cell, it has to attach to a receptor. Subsequently, it has to activate the Janus kinase pathway, thereafter leading to dimerization of STAT, leading to inflammatory as well as anti-inflammatory factors which are activated. So if you have a molecule which blocks the Janus kinase pathway, the JAK-STAT pathway, something like tofacitinib, which is a pan-JAK inhibitor, that will lead to decrease in the production of pro-inflammatory cytokines. So if you look at the kinetics of both these two new molecules which have come up, vedolizumab, which is a monoclonal antibody, and tofacitinib, which is a small molecule. Vedolizumab, the half-life is 25 days. Half-life of infliximab is 7 to 9 days, whereas the half-life of tofacitinib is 3 hours. That you should remember because that makes a lot of difference, because that tells us that tofacitinib is going to act very, very fast. Secondly, vedolizumab is something which is going to act only in the gut. It has a gut homing action. So it will have a slow onset of action probably because of the half-life. Secondly, because it is gut homing, so it would have a very selective action. And obviously, since it has a longer half-life, there'll be longer weaning off if surgery is planned. Whereas for tofacitinib, it is a small molecule, it is non-proteinaceous. So there'll be no immunogenicity, there'll be no antibody formation. It will have a low production cost. It will have a very fast action. And if surgery is planned, then weaning off will also be very fast. Let's not forget the steroids in all this process. Corticosteroids have always remained the cornerstone. Why? Because IBD affects all classes of life, poor as well as rich. And for people who cannot afford many drugs, corticosteroids still remain life-saving for them. In corticosteroids, what have been the advances? Hydrocortisone, prednisolone, methylprednisolone, we find that the clearance rates were low and the oral bioavailability was very high. But came up topical glucocorticoids. Here one would like to concentrate on budesonide. Budesonide has a very high clearance and a low oral bioavailability. It is topical. In other words, the action on HPS suppression would be very less. The side effects would be very less. It is something like if you give prednisolone, which is a systemic glucocorticoid therapy, the first pass effect will only be 20%, but the whole thing is it will be distributed all over the body. You give budesonide. Budesonide controlled release tablets are available earlier. So budesonide controlled release tablets or capsules, if they are given, then the first pass effect is around 90%. 90% of the drug gets metabolized in the first pass in the liver only. And rest of the drug which is being released in the terminal ileum or in the right colon. That is the distal ileum, I would say, terminal ileum and the right colon. This is a very important point to remember. Came up in last 1 year, budesonide MMX, which is again budesonide, but with multi-matrix technology. The difference being that budesonide MMX does not get released in the distal ileum. It does not get released in the terminal ileum. It gets released in the colon, principally in the transverse and the left colon. So this is very important because in cases where you would like to give budesonide CRAs in cases of Crohn's disease, where there's small intestinal involvement, particularly ileal involvement or ascending colon involvement. Whereas budesonide MMX is one which you would like to give in cases of ulcerative colitis. So this is a very important difference and which we should remember, because often if we do not know this difference well, then we may end up prescribing budesonide MMX for patients with Crohn's disease who have small intestinal disease, or end up prescribing budesonide CR for somebody who has principally a colonic disease, and there the action may not be very good. So if I make a list of all the drugs which are available to us right now, with which we can help our patients, so apart from the regular 5-ASs and everything, the higher end drugs we have is budesonide preparations, the controlled release and the MMX, infliximab, adalimumab, vedolizumab, tofacitinib, and surgery obviously is there. It remains one of the cornerstones. So now let us see how do we position our therapies. If we want to integrate budesonide MMX into the treatment for mild to moderate ulcerative colitis, how does a therapeutic pyramid change? The traditional pyramid for ulcerative colitis has been whenever the disease severity increases from mild to moderate, okay, you will move over to 5-ASA and thereafter move over to prednisolone. If patient is steroid dependent, then you will add azathioprine and subsequently infliximab. However, with the introduction of budesonide MMX, what we can see is if a patient has mild to moderate ulcerative colitis, relapse while he's on 5-ASA, you can introduce budesonide MMX, 9 milligrams for 8 weeks and see the response. And if the patient has a good response, you need not move over to prednisolone. You move over to prednisolone only if the patient does not have a response. The algorithm has changed in a way. Active, mild to moderate ulcerative colitis, oral 5-ASA plus topical 5-ASA. Remission, fine, continue. If there's a partial or no response, then in that case, you would like to give budesonide MMX, and thereafter, if there is no response, thereafter you would like to give systemic steroids. Acute severe ulcerative colitis. If there is no response to IV steroids, you have plenty of agents which I have listed out there. So do these agents work? Which one of them would you like to use? Let me add also another variable out here in our country. Our country is vast. It has there's a lot of diversity. So you have patients who can afford everything. You have patients who really can't afford many medicines. There are ulcerative colitis or Crohn's disease being perennial diseases. So as a result, they require medicines practically lifelong. So even for middle class patients who do not have reimbursement, it becomes very difficult to afford many of the medicines. So we have to keep that in account. So on the right side of the panel, I have medicines or agents which may help patients who cannot afford much. And on the left-hand side, I have medicines who will be able to help patients who can easily afford. So what happens in acute severe ulcerative colitis? What would you like to use if the patient is not responding to IV steroids? How do the newer drugs, how do they help us? How do we position them? So you find that infliximab remains the drug of choice for acute severe ulcerative colitis not responding to IV steroids. Adalimumab does not act in acute severe ulcerative colitis, should not be given. It has a poor action. Vedolizumab, remember, long half-life I told you. So as a result, vedolizumab again is not the agent to be used in acute severe ulcerative colitis. Cyclosporin remains an excellent choice, as good as infliximab for acute severe ulcerative colitis, and particularly for this group of people who cannot afford much. Surgery remains an excellent choice, particularly if the patient has had an aggressive history of colitis in past and surgery becomes curative. What about tofacitinib? Tofacitinib is an excellent choice. It has been not randomized controlled trials have not been done, but at the same time, there are plenty of case series and real world data which is emerging, which shows that if you give high dose tofacitinib, 10 milligram TDS for 3 days, thereafter followed by 10 milligram BD for 2 months, the patients achieve a good rate of response. And in fact, even if there's infliximab failure, then you can move over to tofacitinib. This is how the therapeutic algorithm for acute severe ulcerative colitis is also changing in our country. Second case scenario, a patient who has steroid-dependent ulcerative colitis, not responding to azathioprine. Earlier, we had two choices, that is give TNF inhibitors or patient goes in for surgery. Now, I think we are a little bit spoiled for choices as we have again 5 choices. So let us see how can we position these 5 choices. In steroid-dependent ulcerative colitis, which is not responding to azathioprine, all the 5 agents can be used. But out here, if you ask me what would be the first line therapy, what would be the therapy agent of choice, then I would say infliximab and tofacitinib. Infliximab remains the agent of choice in ulcerative colitis. Thereafter, you can go in for vedolizumab, surgery, and adalimumab. However, if the patient is not affordable, he cannot afford infliximab at all, then in that case, the patient can be given tofacitinib in such a setting because tofacitinib has been shown to have an excellent response, not only in naive patients, but also in patients who have failed to respond to infliximab, adalimumab, or vedolizumab. Remember that amongst infliximab, vedolizumab, and adalimumab, infliximab is probably the best when it comes to ulcerative colitis. What about a patient who has steroid-dependent ulcerative colitis, elderly, prone to infection, or probably risk of malignancy, or had a history of solid organ malignancy in last 2-3 years? Again, not responding to azathioprine and all. What would you do in such a setting? You have all these 5 choices. Which agent would you like to use out here? Here in such a setting, vedolizumab scores the best. Vedolizumab, I would suggest that one should use vedolizumab out here as the first line of therapy if the patient is not responding to steroids, has been on azathioprine, which has been ineffective, because vedolizumab has the best safety profile. Since it has the best safety profile, so particularly in people where the chances of infection are very high or elderly, you would like to give vedolizumab. What about a patient of ulcerative colitis, again, which is steroid dependent but has extra-intestinal manifestations? Something like either ankylosing spondylitis or primary sclerosing cholangitis, again, not responding to conventional line of therapy. Which agent can you use? All these agents? Yes, no. And which agent would you prefer the most? What you find out here is that infliximab can be used, adalimumab can be used, the TNF inhibitors can be used, tofacitinib can be used because it's a JAK kinase inhibitor, whereas vedolizumab, because it has a gut-homing action, remember. It acts only on alpha beta 7 integrin inhibitor. So it's a gut-homing action. So vedolizumab has been particularly found to be not very useful in patients with extraintestinal manifestations. In fact, in a recent study in patients with primary sclerosing PSC, it had a deleterious effect. Again, surgery may not be very useful in such a setting because these extraintestinal manifestations, many of them are not dependent upon the activity of colitis, so surgery would really not help. So in such a setting, infliximab, one, followed by adalimumab, or tofacitinib, and if the patient cannot afford, then you can straight away go for tofacitinib instead of infliximab. So this is the kind of what I would say choice we have today, particularly for patients who cannot afford. Where earlier we used to say that okay, we have to give infliximab, how are we going to arrange for infliximab and what to do? There you have an agent which is as cheap as 5S in the sense that it is not very costly and it can be given. And tofacitinib dose remains, as I told you, in acute severe ulcerative colitis, 10 milligram TDS for 3 days. Otherwise, in other settings, there's an induction phase where it is 10 milligram twice a day for 8 weeks, followed by 5 milligram twice a day, which can be given for 1 year or more than 1 year. Now, just 2 or 3 slides on what I feel are problems, are things which you should know, what problems tofacitinib can cause, what are the adverse events of tofacitinib, what you should do before starting such an agent. Tofacitinib can also lead to reactivation of tuberculosis, so you have to screen for latent tuberculosis in terms of MON2, IGRA, or a CT chest. You have the tofacitinib reactivates hepatitis zoster infection, so you have to look for that, if possible, immunize for that. Tofacitinib particularly is prone to cause venous thromboembolism, so if the patient has high risk of venous thromboembolism, you would not like to give them. Besides that, you would like to monitor liver function tests, kidney function tests, and look for cytopenias. The main adverse events, as I've told you, are thromboembolic events or herpes zoster activation. Besides that, it can cause cytopenias or increase in creatinine levels or increase in transaminase levels. It has also been found to be teratogenic. This dose-dependent risk of activation of herpes zoster means that this is seen only when tofacitinib is given for in high doses, 10 milligram BD, induction doses. That is the time when you have these two dreaded adverse events which can occur, herpes zoster reactivation and venous thromboembolism. The risk seems to go down subsequently when you go down to 5 milligram twice a day. So how do you decrease the risk of these adverse events? You look for history of venous thromboembolism. If there's anything like that, you would like not to give that patient tofacitinib. And for herpes zoster, if you have a time period of 1 to 2 months before you have to initiate therapy, you can give the vaccine. The live vaccine is available in India by the name of Zostavax. That can be given, but remember it's a live vaccine. And before you give any immunosuppressant drug, you have to have a time interval of 4 to 8 weeks at least. There's a recombinant vaccine which is available, that is Shingrix, but that is not yet available in India. So if I compare both these agents, particularly for ulcerative colitis, you find that vedolizumab has a role in UC steroid dependent, whereas tofacitinib has a role in every kind of situation of ulcerative colitis, steroid dependent, EIM, second line therapy after infliximab failure, acute severe colitis. But vedolizumab has a better safety profile. It could be the first line therapy in elderly, history of malignancy. Ease of administration is obviously much more with tofacitinib. It's a tablet. The cost obviously it scores very highly over vedolizumab. When it comes to cost, there is no comparison. One is around 5 lakhs for a year, and the other is around 50,000 for a year. Coming to Crohn's disease. Again, we have the rich people, we have the people who cannot afford steroid-dependent Crohn's disease. We have all these therapies. What would you like to use if the patient is not responding to azathioprine? Here, remember, tofacitinib clearly goes out, immediately goes out, because tofacitinib has not been found to be effective. Cousins of tofacitinib like filgotinib, which are going to come up, are effective in Crohn's disease, but at the moment, tofacitinib you would not like to use in a patient with Crohn's disease because RCTs did not show that it did not provide statistically significant benefit. So that leaves you with these agents. Which of these agents you would like to use? Here, the first line agents can be infliximab or adalimumab, because they are equally effective in patients with Crohn's disease, and vedolizumab, again, because it has a slower onset of action, somehow in very aggressive Crohn's disease or where the inflammatory burden is very high, it does not seem to provide immediate benefit. The benefit may build. And remember, surgery is a very, very good option in Crohn's disease. Whenever there is a failure of any of these agents, you can switch the agents and move on to the other agent. What about B2, B3 disease? Fistulizing or stricturing Crohn's disease. No response to azathioprine. As I told you, tofacitinib is already out. What would you like to use? Again, infliximab or adalimumab should be your first-line therapies. Vedolizumab and surgery should be your second-line therapies. This is something you should remember as such. Why surgery can be considered also as a first-line therapy? It has been, there's a recent data has come out which is very encouraging and particularly important for our country where cost remains an issue. It was seen that if there's a limited terminal ileal disease, less than 40 centimeter of TI involvement, non-stricturing disease, failure to respond to steroids, usually next to us is biologicals. So if you do a laparoscopic ileocecal resection, what are the results? So the trial, a randomized control head-to-head trial was done, which looked at laparoscopic ileocecal resection versus infliximab for terminal ileitis, and then we had follow-up for 5 years, and the results of the follow-up also came, and the results of the initial trial were that the quality of life was similar whether you did surgery or gave infliximab, and the results for 5 years were that in the 5-year resection group, nearly half did not require any therapy at all when they were operated upon. Only 1/4 required biological therapy. And in infliximab group, all patients required surgery and half required continuation or escalation of biologicals after that. Half required surgery, all of them required therapy, suggesting that in general, when it comes to early surgery, there is evidence emerging that particularly for ileocecal Crohn's disease, when conventional therapy fails, commonly scaled up you'd scale up to biological agents, here surgery can be used. What about IBD with pregnancy? What will be the algorithm out there? Remember again, tofacitinib is out. Again, now whether it is ulcerative colitis or Crohn's disease, tofacitinib is teratogenic, so it cannot be used in pregnancy. What about rest of the agents? So we find that infliximab, adalimumab, they have plenty of data. They are safe in pregnancy. Vedolizumab, considered safe, but still there is limited data, so it can be considered as probably safe. So this is what you would like to do in pregnancy. Can biosimilars be stopped? Can biologicals be stopped? Or biosimilars, can they be used? So this has been a concern amongst people in India when you use biosimilars, that although they are reasonable, are they giving similar kind of efficacy as biologicals? So 2 studies out here showed that they seem to be doing as well as the original molecules, as this study showed that adalimumab biosimilar was as effective in inducing and maintaining remission in patients with Crohn's and ulcerative colitis. And similarly, when infliximab biosimilar was used and it was compared with the infliximab originator molecule in 137 patients, 102 original and 35 biosimilar, both were found to be similar. Similarly, what is the relapse rate following withdrawal of anti-TNF therapy? You find that if you can stop biologicals after 1 year or more, if patient is in clinical and mucosal remission, you would like to continue azathioprine or methotrexate. But remember, there's a 42%, 50% relapse rate at 1 to 2 years, and most relapses occur within 6 to 12 months. Now coming to the third set, I'll just take 1 or 2 minutes more, please. We have talked about rich and poor, but there is a certain set of cases, regardless of rich and poor, which are refractory cases, which are extremely challenging, and treating physician really does not know what do you do for them in our country. One is you can try and use exclusive enteral nutrition, because it has been seen that in patients with complicated Crohn's disease, exclusive enteral nutrition is effective both as an adjunct as well as the only treatment in inducing remission. We found that about 2/3 of our 32 patients, they experienced clinical remission by 8 weeks. Another therapy which can be tried is hyperbaric oxygen therapy. We used that as a pilot trial in 14 patients with small bowel stricturing Crohn's disease, and we found that 50% of them showed a good response. They were given on a median around 11 sessions, 1 hour session, around, you can say 10 sessions spread over 4 weeks, and 50% of them, these very sick patients, did show a response, not only clinical response, but also radiological response. FMT, Dr. Sood has already talked about it. Here, one thing I would like to show that even when you do a network meta-analysis, it was seen that FMT is as effective as rest of the biological agents in inducing remission and response in patients with mild to moderate ulcerative colitis. Finally, perianal fistulizing Crohn's disease, they can be really, really tough to treat. So we have been using mesenchymal stem cell injections in them as a part of trial, where the patients are selected which have only one tract. Subsequently, the fistula tract is curated. Thereafter, the freeze-dried reconstitution mesenchymal stem cells are injected, and subsequently they have been followed up for 1 year. We have already done it in around 6 patients till now as part of a trial. And in these 6 patients, we have seen that 3% of them till 6 months and subsequently even till 1 year, they have shown a 100% response, whereas there was only one patient which did not show any response at all, and 2 patients showed a 50% response. But remember, these are sick patients who have tried every other kind of therapy before. So such a kind of response in such kind of patients where there is not only radiological healing, but if you look at the figure out here and the right out here, till 1 year, if you are getting this kind of response, this is certainly very useful. And finally, you can also try in specialized centers, I would say, where dual biological therapy or biological plus small molecular therapy, this is undefined therapeutic class combination. Why? Because we have been acting only on, we have been using agents which act only on TNF alpha or IL-23, but however, ulcerative colitis, Crohn's disease, they can have lot of cytokine helps. So these are the kind of combinations which can be used in very specific in patients. Again, you have to be very careful when you're using these combinations. The data is still there emerging in terms of case series and all. There are no RCT trials available. So you can use a combination of anti-TNF inhibitor plus vedolizumab if the patient is not responding to anything at all, or an anti-TNF inhibitor plus tofacitinib, or vedolizumab plus tofacitinib. These kind of combinations can be tried. So finally, to conclude, we have a lot of agents which are available in our country already, and we should be aware that how we have to position these agents. And in a way, you know that tofacitinib is an excellent drug for ulcerative colitis. Vedolizumab is a very good drug for elderly. Vedolizumab is a good second-line agent, I would say, for Crohn's disease till the time ustekinumab is available. Surgery should be kept in mind, both not only for ulcerative colitis but for Crohn's disease. And when nothing works, there are some things which you can try: dual therapy, hyperbaric oxygen therapy, exclusive enteral nutrition, or stem cell therapy is also available. And finally, in next 1 or 2 years, there are plenty of agents which are already coming up, but I have not even talked about them because I feel that since they're not available in the country, so at the moment, if we are restrict ourselves to our discussion with the agents which are available, that would be more fruitful. Thank you so much for your attention, and sorry for overstepping the time, please.
Thank you, Dr. Vinit Ahuja, about your excellent presentation. You have well presented the safety issue as well the efficacy. Now there will be a discussion. Over to Dr. S.P. Mishra.
May I request the panelists to start asking questions? I have some questions in the chat box too. I'll be reading them. So just one question because it's...
Yeah. Can I ask a question?
Yes, sir. Go ahead, sir.
Yeah. You suggest JAK2 inhibitors for severe ulcerative colitis also. But at the same time, you suggest the immunization also, because they have to be immunized for virus and the herpes also. Now, it is very difficult. So do you suggest that all patients of ulcerative colitis should be first immunized? And whenever there is a severe case, then you can start the JAK2 inhibitor, because in a severe situation, you cannot wait for the immunization to work actually.
Yeah, you're very right, Dr. Patwari. As I suggested in that slide itself, that if you have a 1 to 2 month time period in some cases like steroid dependent or something like that, there in those cases you can think of immunization. In an acute setting, you cannot think of immunization. There you have to simply go. So it is not possible. But wherever it is possible, kindly do.
Monica has some question.
Can we treat these patients with for herpes zoster and then restart this tofa?
No, I don't think, ma'am, there is data that you should give antivirals and then that would limit the reactivation. So we do not have very good data for that. However, if the patient has previous history of herpes zoster, then probably the patient has antibodies, so that may be protective. So herpes zoster is seen in roughly 2 to 3% of cases. So, and that would also be seen when the dose is high, 10 milligram BD. Subsequently, the risk definitely decreases. So right now, the only strategy would be either you vaccinate them or otherwise, as soon as you have achieved some induction, then you decrease the dose. If you decrease the dose, then you decrease the risk. So don't give 10 milligram BD for a longer time.
Please, can we start with 5 milligram only, not 10 milligrams?
10 milligram will not be effective, so you need an induction dosing. And in acute severe ulcerative colitis,
That is causing the problems.
in acute severe ulcerative colitis, you need 30 milligram a day for 3 days. Thereafter, 20 milligram a day for 8 weeks. In steroid dependent, you would like to start with 10 milligram twice a day for 8 weeks.
So there's a comment from Dr. Setu about what about probiotics?
Probiotics, Dr. Sood talked about. Dr. Sood showed his trial about BSL-3 in mild to moderate ulcerative colitis, which was significantly superior. But as in all sessions we have discussed, none of us end up using BSL-3 because the dose used for that BSL-3 was somewhere around 90 billion or something, which means around 25 sachets a day, which is not practical. Was also not economical.
So, and the second question, Dr. Ashish Kumar, is for almost all situations discussed, infliximab seems to be effective. Is that right?
There is no doubt about that. That infliximab in ulcerative colitis, it is superior to adalimumab as well as vedolizumab. In Crohn's disease, it is superior to vedolizumab for sure, equal to adalimumab. The only thing is that once ustekinumab comes up, then at that time, that is one agent which would rival infliximab. At the moment, infliximab would remain first-line therapy, except tofacitinib may probably replace it. At the moment, the evidence is more for tofacitinib as a second line of therapy. But in a country like India, where cost is a major issue, so tofacitinib can be given straight away after steroid failure rather than waiting for that.
Dr. Ajit, do you have a question? Unmute yourself, please. Dr. Ajit?
Sir,
yeah.
I would like to ask a simple question, sir. How effective is curcumin in this inflammatory bowel disease, especially in ulcerative colitis? So, because it is a part of our diet.
So curcumin is, we have tried curcumin in 2 forms, oral form and enema form. What our experience was when we did the RCT with oral curcumin, we did not find it to be effective, but then we used low doses at that time. Subsequently, 1 or 2 trials have shown that if you use it in high doses, going from 1 gram to 2 gram a day, it may provide some kind of benefit, but again, the data is flimsy. Whereas when we use curcumin as enema form in patients with proctitis, we found there was definitely significant relief in patients. The per protocol analysis was statistically significant in terms of that there was significant difference for patients who were using curcumin as enema form, but that is still not available commercially.
Can we give anticoagulant prophylaxis with the SOFA?
Excellent point, ma'am. If you are giving 10 milligram BD, particularly after acute severe ulcerative colitis, you do give anticoagulant prophylaxis when the patient is hospitalized in a patient with acute severe ulcerative colitis. So you should continue that in the oral tablet form once the patient is discharged if you are giving tofacitinib.
Won't you give anticoagulation even otherwise in ulcerative colitis?
Can we give, sir?
No, even otherwise, won't you give? Will you not give anticoagulants?
In acute severe ulcerative colitis, we do give anticoagulation when the patient is hospitalized. So you stop it when the patient is discharged. But if you're giving tofacitinib, then you can continue that. And if the patient is going in for surgery, then we do anticoagulate that patient prophylactically always, and preferably for 2 to 3 months if possible.
Dr. Sachdeva, you have a question?
First of all, happy Teachers Day, Dr. Vinit. Okay. And I have got 2 questions. One is, what is your experience as azathioprine as maintenance in terms of their safety? Because in a very short period of time, I have seen 2 patients with a lymphoma. That is very, scary to me.
We analyzed that data very recently, and we had patients more than 5 years. We had around 1,000 patients who were on azathioprine, let's say 250 patients who were more than 5 years, and 70 patients more than 10 years of azathioprine therapy. We did not get even a single case of lymphoma. And I have not, it's again a question of you have seen, so obviously that makes in the sense that you have a point out there. But in our experience, we have not seen a single case of lymphoma, despite having a very large cohort, I would say. And with 250 patients, more than 5 years of therapy is a fairly good.
Correct. Second question was, where is the role of this therapeutic drug monitoring, especially when we are, using azathioprine, methotrexate, as well as, TNF inhibitors? Where do you keep TDM?
TNF therapeutic drug monitoring is very useful, particularly if you find disease is active and the patient is losing response, you measure drug levels. If the drug levels are high and the patient does not have a response, then you know antibodies are being formed and you can measure the antibodies also and accordingly change the drugs. For azathioprine, pharmacogenomics is important, that you would like to do NUDT15 polymorphism before starting it. And subsequently, if you want to measure the response, then you can measure 6 TD and 6 MMP levels. For methotrexate, such kind of monitoring is not available.
Dr. Vineet, how?
Monica, go ahead.
There's an interesting question by Dr. Anil Arora. Why is TOFA?
Yeah. Oh, you're already reading it. I was going to read that. No.
Because, sir, in TOFA is a pan-JAK kinase inhibitor, whereas it has been seen that particularly JAK1 inhibitors have been found to be more effective in Crohn's disease. So JAK1 inhibitors or type 2 inhibitor, tyrosine kinase inhibitors, they may be useful in Crohn's disease, whereas a pan-JAK inhibitor, because of some of the beneficial effect which JAK3 may be giving, so as a result, that was not found to be useful in Crohn's.
Maybe you can read the questions too then.
I should read the question, sir.
I think so. You started the ball rolling now.
Should azathioprine be stopped before starting tofacitinib? Yes, it should be stopped before starting. Why not use tofacitinib as first-line agent after 5 ASA, even ahead of steroids? No, I don't think so, because tofacitinib has an adverse event profile. And steroids, how do you know that you have given 5 ASA? The patient will just require one steroid course in 2 or 3 years. It's only when the patient becomes steroid dependent, then you know the patient is going to have steroid toxicity. There also, it will be better right now to give azathioprine, because adverse event profile of azathioprine is still better compared to tofacitinib. So tofacitinib is an excellent drug, but it comes with a price in terms of adverse events. So you have to use it when it is really.
What should be the regimen for tapering the steroid when we are starting TOFA?
So ma'am, out there, generally you taper steroids over 3 to 4 months. Then people taper in 5 milligram 2 weeks, or initially 5 milligram every week. But the whole thing is that initially TOFA acts very fast. It acts, half-life is 3 hours, it acts within 3 days and all. But once the effect builds up, then you can taper it really fast. So there is no set rule for that. But initially TOFA also requires some support when the disease is aggressive. You cannot only start TOFA and hope that it will happen. That time you want to give some amount of steroids, then you can taper off steroids within 4 to 8 weeks, much faster than the way you normally take steroids.
Need any experience with diversion ileostomy?
So diversion ileostomy is very useful in patients with Crohn's disease. The only problem is that around 30 to 40% of patients, the disease relapses after 1 to 2 years. Then you are never able to close the ileostomy. So particularly for young patients, you end up doing it because you again do not have any other agent available. But one should be careful. One should be aware that there'll be a relapse for 30% after 1 to 2 years.
Dr. Vineet, after 5 ASA, why not use tofanate way ahead of steroids?
But I just answered this question. To put it again, TOFA has an adverse event profile. So in such case, let's say 5 ASA, patient requires steroids. He may require steroids once in 2 years only. He may require steroids once in 2 years every 2 years. So that way, he'll not be steroid dependent and the adverse event profile will not be high. So you would like to use TOFA only when there's a steroid-dependent disease, not responding to azathioprine, because then the person has really earned tofacitinib, and there you can balance the risk and the benefit profile can be balanced in that.
There's a question. Just a minute, Monica, hold on, please. There's a question from Dr. Shobna Bhatia. For CMV positive patient, when to start treatment for CMV?
When to CMV positive patient, as soon as you find that CMV is positive, but provided the patient is symptomatic, one. Secondly, in a setting where you have deep ulcers or the patient is symptomatic. And thirdly, if you have done tests, and particularly if you have done a DNA, you have the DNA copies value, that obviously if you have high DNA copies value, you would like to start it. Or if you have immunostaining, which is positive, then you would like to start it. Or if the patient has inclusion bodies, then you would like to start it.
Started with ganciclovir?
You would like to give ganciclovir for 15 to 20 days, or you can give ganciclovir for 3 days, followed by oral valganciclovir, 900 milligrams PT.
Okay, there are many questions. Monica, just hold on, please, because the questions are important. We are doing CME for them, basically. IBD in children with severe disease vis-a-vis adult presentation regarding use of tofacitinib in younger than 18-year-old steroid-dependent ulcerative colitis. So use it in children.
So use it in children. Again, here the data is emerging. Here I don't think we can we are very clear about it out here because we have much more data for biologicals out here. So here you would like to give biologicals.
Any experience throughout the world about use of tofacitinib in children?
I'm not aware. So this particular point, I'm not aware.
And other question is from Dr. Kamlesh. How long do you give biologics and then step down?
How long do you give, sir?
Biologicals.
Biologicals you can give infinitely. Again, if any given patient, you may, if the patient cannot afford, you may after 1 year or 2 years, if you find there's a good clinical response plus mucosal response, you can stop biological and continue the patient on azathioprine. But if the patient is affordable, I would say give for 3, 4, 5 years, and then you can think about stopping it. Don't stop it.
There's a question from Dr. Mayank about tacrolimus enema.
Tacrolimus enema is very good, very useful. Again, one of those kind of agents which you would like to use when pushed against the wall. They are effective.
Only for left-sided or pancolitis?
Only for tacrolimus enema will depend upon the volume which is used along with it. Tacrolimus are not available, so you make it yourself. You take tacrolimus tablet or something, dissolve it in water, push it. So if you give 10 ml of water, it will go only to the rectum. If you give 50 ml of water, it will go above the sigmoid. So in proctitis or left colitis, you would like to use.
Any chance of getting a foam for tacrolimus foam?
Intas is, I think, doing a trial with tacrolimus enema. So once the trial is completed, they should be marketing it.
Sorry, Monica, sorry for holding you up. Monica, go ahead.
Sir, can we treat the repeated flares with the restarting tofa at higher dose? If a person gets acute attack treated with tofa.
No, I think if a person is on tofa, the person is doing well, and the person is on maintenance dose, let's say 5 milligram BD.
Oh.
And if the person starts getting repeated flares, that means that that particular pathway is not blocking, that particular pathway is not very effective, or there is some other cause which is there which is causing the flare, whether it is NSA to superimpose infection, TB, cancer, anything like that. So you should evaluate the patient and you should not keep on increasing the dose.
And CMV too, I believe.
Pardon, sir?
CMV also you have to evaluate.
CMV also, Clostridium difficile, CMV, TB, cancer, all these.
So we have 45 seconds left. Any question?
Is there any role of salazopyrin in ulcerative colitis with ankylosing spondylitis?
Yes, sir, it is useful, but then it is a very mild drug. So for mild symptoms, it helps. Particularly for severe pain, it is better you give to give biologicals anti-TNF because they will take care of colitis as well as ankylosing.
Dr. Vineet, patient with extra-intestinal manifestation, TOFA has a role. We had a patient who had skin lesion also treated with TOFA.
Monica, short question.
So that's what I told in the algorithm.
How long to give TOFA in such case?
You will give TOFA in such case if whether you're treating for skin or for colitis. If you are in the sense that even if you're giving for skin, often if you stop it, there'll be a chance of relapse of the skin lesion. Something like pyoderma gangrenism, anything like that, there would be chances to relapse the moment you decrease immunosuppression. So it will be better to give it for a long time.
Yeah, time is up. Thank you very much, Vineet. I thank my co-chair, Dr. Swami, and all the panelists and people who have asked questions and have listened to the talk. Thank you very much. Move on to the next topic. Dr. Ashish.
Thank you, Dr. Mishra, and thank you for sticking to time and also taking all the questions. And thank you, Dr. Goswami. So we move on to the next session. That is a very interesting debate on treatment of dyspepsia with anti-H. pylori drugs. So moderators for this session are Dr. Anup Saraya and Dr. Shiva Prasad. Dr. Anup Saraya is from AIMS. Dr. Shiva Prasad is from Visakhapatnam. So I invite both of them to take over this session.
Thank you. And I welcome you all in this session. It will be a very interesting debate. And two speakers, they are outstanding speakers. Both are known to this audience. Dr. Usha Datta, she is head of the Department of Gastroenterology at PGI Chandigarh. She is a clinical fellow of Stowe Liver Unit, University of Sydney, and a fellow of American College of Gastroenterology. She is a clinical fellow at McMaster University. She will be speaking for the motion, and Dr. Uday Ghoshal, he is also well known to this audience. He is professor of gastroenterology at another prestigious institute, PGI Lucknow, and he is a fellow of American College of Gastroenterology, fellow of Rome Foundation, and he is currently the editor of Indian Journal of Gastroenterology. Apart from that, we have a distinguished panel Professor Dilip Sharma. He is a leading clinician and academician. He is a health system expert, and he is a cabinet physician to the government of Nepal. He is a public health expert also. Then we have Dr. Nandu Odial. He is on the faculty of Veer Hospital, Nepal. Dr. M.P. Sharma, he is former head of the Department of Gastroenterology at All India Institute of Medical Sciences. And after superannuation, he is associated with Rockland Hospital as consultant. Then Dr. Parimal Lavate, he is director, GI and liver transplant at Jahangir Hospital, Pune. He is a consultant there. And Dr. Piyush Ranjan, who is a senior consultant and vice chairman affiliated to Sar Gangaram Hospital. So I'll invite Dr. Usha to speak for the motion.
Thank you, Professor Saraya. Are my slides visible?
Yes.
Yeah, good evening, everybody, and thanks to Dr. Anil Arora for organizing such a stimulating conference. And thanks, Vineet. We had a very good lecture just now. My topic here is on H. pylori should be eradicated in non-ulcer dyspepsia in India. So each of the words are loaded and have an importance. So let me take you through each one of these. H. pylori should be eradicated in non-ulcer dyspepsia in India. I will be speaking for the motion. H. pylori is an old bug. It's associated with the human gut for over 50,000 years. It is far more intelligent than any one of us. It is there with man since he came out of Africa. It has been seen in the mummies, and it is the commonest infection in mankind. 50% of the world is infected with H. pylori, and it is a marker of a poor sanitation status and thus very common in India. And it is not a commensal organism. It causes disease. It hides under the mucus layer, has a urease enzyme which protects it from the acid and stays there and thrives there and causes inflammation in the form of cell injury, causes atrophy of the gastric cells, resulting in loss of gastric function and acid production, which acid is a very protective thing for our gut, and it leads to loss of that and causes various mutations in the DNA and causes gastric cancer. Even if it is asymptomatic, it is associated with cell damage in the form of antral gastritis, gastric atrophy, metaplasia, dysplasia, and cancer. And in symptomatic patients, we have seen this end of the spectrum. They can come with bleeds and malignancy. But the damage is on even in patients who are asymptomatic. So though 80% of H. pylori infection is asymptomatic, all of them have chronic gastritis. Means H. pylori, if present, there is damage, and that damage control has to happen. What is new about this old bug? The Kyoto Global Consensus Report on H. pylori gastritis was the first one which gave it a status. Despite its discovery long ago, it did not have a status. Even in ICD-10, it didn't have a status. And it was proposed by Kyoto that H. pylori induced gastritis should be a separate entity. In ICD-11, it has been incorporated. Another thing which happened is in non-ulcer dyspepsia, that means a patient in whom you do an endoscopy and do not find an ulcer, you should still investigate for H. pylori, eradicate if present, and if the symptoms are improved, then we call it as H. pylori associated dyspepsia. So this was the next contribution of Kyoto, which suggested there is a separate entity of H. pylori associated dyspepsia. So you have to exclude it before we make a diagnosis of functional dyspepsia. So this was another major change in Kyoto, and thus Rome 4 incorporated this component and said that functional dyspepsia can be diagnosed only after eradicating H. pylori. So these are the three main components which came out of Kyoto. And the next important component which came out of Maastricht 5 is another consensus document which suggested that H. pylori gastritis has to be excluded before a reliable diagnosis of functional dyspepsia can be made. And note that the level of evidence is high and the grade of recommendation is high. Just give me a minute. So next comes the issue of the Kyoto Global Consensus also suggested that it needs to be eradicated irrespective of the functional status of the disease. And this was subsequently followed up by the ESPGHAN as well as the Maastricht-Florence consensus report, suggesting that any H. pylori, if seen, should be eradicated because it's a class 1 carcinogen. So the effect of H. pylori, it has effect on the symptoms. It is also a source for transmission to family members, general population, endoscopists, and it causes gastritis and peptic ulcer, atrophic gastritis, malignancies of the stomach. So if we eradicate it, this will result in reduction in symptoms, reduction in the gastritis, and reduction in the transmission into the community. And by this, we will reduce the source control by removing H. pylori from the community. In a recent study in Hepato, they have shown that the recurrence rate is less than 1% and the community incidence of H. pylori goes down significantly. So who needs treatment? This is what is the Maastricht 5 recommendation. Definitely patients with peptic ulcer and also patients with gastritis, gastric atrophy, dyspepsia before starting PPI for dyspepsia and asymptomatic H. pylori infection. Note that all of these can come under the big banner of non-ulcer dyspepsia. So all those patients with non-ulcer dyspepsia also need therapy for H. pylori. So when to eradicate? Whenever you see it, eradicate it as soon as possible, because once intestinal metaplasia happens, it is not reversible, and hence any eradication should happen before this happens. Secondly, attributable risk for gastric cancer is as high as 89%. All other factors are not as important as H. pylori in the causation of gastric cancer. Empirical PPI therapy in non-ulcer dyspepsia without eradicating H. pylori is a big problem, because it will increase the corpus dominant gastritis, cause increased SIBO, increased cancers, and increased atrophy. So it is detrimental to not eradicate H. pylori before treatment with PPI. Symptom relief in a large study on 404 patients, when they found the eradicated group had 49% reduction in symptoms compared to 36% in the PPI alone group. And global improvement was also in 78% compared to 67%. The NNT was 8. So 50% of the patients get 50% relief in dyspepsia symptoms at 1 year after anti-H. pylori therapy. Symptom relief on a meta-analysis shows that 33% greater relief in symptoms, 54% greater relief in symptoms in Asian studies, and in Indian studies, there was a 81% symptom relief versus 30% in the placebo group, and another study from Srinagar, 60% versus 52% in the placebo group. It reduces hospital visits, 25% reduction in hospital visits in the treatment group, 75% reduction in peptic ulceration, 7 times improvement in histology, 54% reduction in gastric cancer incidence, more so in patients without ulcer disease, 55% reduction in gastric cancer. And in a recent study on mass eradication in the community in the Matsu Islands, it has shown that the prevalence of H. pylori after eradication in the community significantly drops, suggesting that source control, if it is taken away, the amount of H. pylori burden in the community goes down. This is associated with significant reduction in the gastric cancer in this community. However, the adverse event is not too much, only 2 times increased. Short-term adverse event, most of them are minor. So all our features suggest that benefit outweighs the risk. Eradicate H. pylori whenever you see it, whether it is in India or in non-ulcer dyspepsia. There has been a concept of Indian enigma that we have had a lower gastric cancer incidence in patients with H. pylori, but I think the protective factors like ginger, turmeric, and fresh fruits and vegetables, which is common in our country in contrast to the smoked fish and non-vegetarian in other country, must be working in protecting us from this bug. In Japan, Taiwan, China, people go to door to look for this bug. Whereas in India, when the bug knocks at our door, when the patient has non-ulcer dyspepsia and antral gastritis RUT is positive, and we still think we should not be eradicating it. Actually speaking, The benefits: symptom relief, cancer reduction, ulcer reduction, bleeding reduction, iron deficiency reduction, community transmission, all of that are the benefits, and which significantly outweigh the risk in the form of a transient cost, logistics, possibility of resistance, reinfection, and recrudescence. So push it even if it is difficult. If we want our country to become a developed country, the think tanks of our country have to think like a developed country. We cannot think like a developing country to become a developed country. We have to change our mindsets. And I would rest my debate here to say that all H. pylori needs to be eradicated, even if it is a non-ulcer dyspepsia, even if it is in India, because the benefit outweighs the risk of treatment. I would say look for it and treat it. Thank you.
Thank you, Dr. Usha. That was a very, very cogent and a very powerful argument in favor of treating all patients with functional dyspepsia. But we do realize there are two sides to this coin. And if it was not so, it would not be a topic of debate. And now invite Dr. Uday Ghoshal to come up with the opposite side of the story. And as why is it that we should not be treating everybody with dyspepsia in India for H. pylori eradication? Dr.
Yeah,
Uday,
so
please.
can you unshare Dr. Usha so that I can start sharing my slides?
I will.
Yes, Dr. Usha, can you please
Yeah, I'm just sharing.
stop sharing, please?
Just stop
You go to
sharing.
the top that stops sharing, is there?
Stop sharing. Yeah, sorry. Yeah, sorry. Go ahead, Dr. Ghoshal.
Okay, thank you. Thank you so much. Thank Dr. Usha. Can you see my slide?
Yes, yes, Uday, can go ahead.
Yeah, so let me tell you, Dr. Usha gave a sort of general overview of why we should see H. pylori anywhere and eradicate. But what I would do is that I would talk about H. pylori, why we should not make a standard policy to eradicate in functional dyspepsia. We currently call functional dyspepsia. In the earlier version of Rome, we used to call non-ulcer dyspepsia in India in particular. So I'm talking about India, and I'm talking about non-ulcer dyspepsia or functional dyspepsia. Just understand, anybody who does not have ulcer and has dyspepsia is not non-ulcer dyspepsia. Non-ulcer dyspepsia is a specific entity. Currently, we are calling as functional dyspepsia using a specific set of criteria. Now, this is the Rome 4 committee member. So I am happy to tell you that I was one of the members in this Rome 4 committee, and we thoughtfully decided that yes, there should be a change. The change should be that patients of functional dyspepsia, before you diagnose them functional, you eradicate H. pylori. And if still the symptom persists, then you call it as functional dyspepsia. Now, let me tell you, this is what we said, that if somebody comes with dyspepsia, if there is no alarm feature, you can even treat empirical. But otherwise, generally, you do an endoscopy. You also look for H. pylori. And if H. pylori is positive, treat H. pylori, document eradication. And if symptoms still persist, then you call it as functional dyspepsia. Now, let me tell you, we were very much influenced by this Kyoto consensus. We all know that Kyoto consensus was held in Kyoto, Japan in 2014, and where a lot of workers who worked in H. pylori, they met. And the primary reason of this consensus was H. pylori is a bad germ. It causes cancer. But what is the risk of cancer? 1 out of 100. If 100 people are infected with H. pylori, 1 develop gastric cancer in Japan, in China. But maybe in India, it is not so. I'll show you some data. So therefore, the people of China, Japan, and many other countries where gastric cancer was so common, they really tried to enforce upon this committee that we should not diagnose functional dyspepsia until unless we eradicated H. pylori. And if somebody's dyspepsia symptom disappeared, we should call it as H. pylori associated dyspepsia. So all the consensus that came later, including Rome guideline, SCG guideline, AGA guideline, Maastricht guideline, all of them followed the Kyoto consensus recommendation because of gastric cancer risk. But what is the gastric cancer risk in India? We know, because of shortage of time, I'm not going to review all the epidemiological data, but in short telling you that China and Japan are high gastric cancer areas. On the other hand, there are certain places in the world, such as Colombia, such as India, such as Africa. These places don't have so much gastric cancer, though H. pylori frequency is very high. For example, gastric cancer frequency in Japan is 110 to 140 per 100,000 population, though H. pylori frequency in adult is 40 to 50%. Whereas in India, H. pylori frequency in adult is about 70%, but gastric cancer frequency is 10 out of 100,000 population. And this had been variously named as African enigma, Indian enigma, Colombian enigma, and so on. And Dr. Usha already reviewed that dietary factor, genetic factor are important. Now, what is the frequency of functional dyspepsia? This is the global epidemiology study from Rome Foundation that we published in Gastroenterology last year. And you can see 40% of world population suffer from one or more functional gastrointestinal disorder. That means if you take 100 people in the world, then 40 would be suffering from one of the functional gastrointestinal disorder. And obviously functional dyspepsia is the commonest. That basically means that every 40 people, I have to eradicate H. pylori first, and then only I can label him as functional dyspepsia. Is it worth doing? Possibly not, because look at the pathophysiology of functional dyspepsia. H. pylori is in one corner, but there are several issues such as psychological dysfunction, duodenal inflammation, altered gut microbiota, gastric motility abnormality and compliance abnormality, and visceral hypersensitivity abnormality. So therefore, H. pylori cannot be a magic bullet that every FD I just give anti-H. pylori therapy and the job is done. Now, also, there are two types of functional dyspepsia we all know. One is called epigastric pain syndrome and other is called postprandial distress syndrome. Epigastric pain syndrome may have acid-related abnormality, H. pylori-related abnormality, but postprandial distress syndrome has totally different mechanism such as accommodation dysfunction, delayed gastric emptying, and so on. And look at the frequency of postprandial distress syndrome. If you take all patients of functional dyspepsia, 10 out of 100 have epigastric pain syndrome pure variety. The rest, 90%, have either postprandial distress syndrome or postprandial distress syndrome, epigastric pain syndrome overlap. So even if you take 100 patients, maybe out of 10, 50% would benefit. So in 100, probably 5 or 10 will benefit. Now, this is the meta-analysis that Dr. Usha already showed. And look at this meta-analysis. This side favors control. That means no therapy for H. pylori. This side favors treatment for H. pylori. And you can see most of the studies which have narrow confidence interval, large sample size, are on the right side. And the number needed to treat is 14 patients. So that means if I treat 14 patients against H. pylori in functional dyspepsia, one will benefit. So that is number needed to treat. So number needed to treat is 14. And also look at this. Patient with epigastric pain syndrome more often respond than postprandial distress syndrome. And I told you postprandial distress is the common variety. I know there is a Chinese meta-analysis including 7 studies, and they found that in the previous meta-analysis 1.38 was the odds ratio. That means if you eradicate H. pylori, you have a little 1.3% chance or threefold chance of getting dyspepsia improvement. But in this Chinese meta-analysis, it is 3. But you have to decide whether taking Chinese studies, you will like to decide Indian policies. I leave it entirely up to you, whether you want the Chinese studies to be extrapolated to decide your Indian policy. Also, we now realize that SIBO is going to be commoner in functional dyspepsia. Here is a meta-analysis that shows the SIBO occurs in functional dyspepsia more common than healthy control. And look at these studies. These are 2 big studies where one side H. pylori therapy, black boxes, and placebo therapy, or rather standard therapy. You can see initially there is a better response with H. pylori eradication, but subsequently even the response became parallel or similar as time goes by. What could be the reason? The reason could be it is primarily the effect of antibiotic rather than H. pylori eradication. It is driven primarily by gut microbiota dysbiosis, SIBO, rather than specific H. pylori eradication, because that's why you see initially there is a reduction in the symptom of FD patient with anti-H. pylori therapy. Subsequently, during 12-month follow-up, it is same whether somebody received H. pylori therapy or placebo. And this is Victoria Tan's landmark paper published in 2017, where you see showed that if you give rifaximin alone, even rifaximin alone led to benefit in functional dyspepsia. Therefore, it suggests that all these studies that we are doing H. pylori would reduce symptoms were related to SIBO in functional dyspepsia. Any one antibiotic will do that, but that will be a temporary effect. Let us examine now the Indian literature. These are the 2 Indian studies. I will say good quality studies because these are randomized controlled trial where they took H. pylori related dyspepsia. This is currently in press, going to be in PubMed very soon. And this is from Dr. Piyush Ranjan group from Gangaram, the organizers of this conference. And what they found is very interesting. When they eradicated H. pylori or gave standard medical treatment to HP positive functional dyspepsia, what they found is that there was no difference in the symptom resolution, whether you gave standard medical treatment or H. pylori therapy, both on per protocol analysis as well as intention to treat analysis. And you can see here, their HP positive was 77%. That means you would have eradicated all these 77 with anti-H. pylori therapy, and then you would have found nobody improved, and therefore you would have labeled them as functional dyspepsia. What great we would have achieved. Now, this is another study published quite some time ago. Again, a good quality study from Sere Kashmir by Shaukat Ali Jargar group. The result is very similar. That means after H. pylori eradication, there was, compared to the standard treatment, there was no difference in the resolution rate of functional dyspepsia. So these are 2 good quality Indian studies. Both suggest there is no point in doing H. pylori eradication therapy because all these 58% patient here and all the 77% patient here would have given them anti-H. pylori therapy, would have caused side effect, and Dr. Usha told you 5% have severe side effect who cannot complete the therapy, and 20% have good number of side effects to the extent they will leave your clinic. They will say this doctor is not great because he caused more illness in me rather than giving me relief. So you have to decide whether you want to be a blind believer of whatever happens in the West and try to extrapolate the same in your country, then probably science of the country will not go forward and will never be leader. Because to be a leader, you have to question based on your data. Therefore, I will conclude that currently international guideline, including the Rome guideline that we published in 2016, suggests that persistent symptom following successful H. pylori eradication should be diagnosed as functional dyspepsia and others as H. pylori associated dyspepsia. The limited Indian data suggests that H. pylori eradication does not provide symptomatic relief to patients with functional dyspepsia in India. Considering very high frequency of H. pylori infection in India and low response rate, and also considering the high frequency of functional GI disorder in the community, anti-H. pylori therapy for every patient with FD may be perhaps wasteful, and we have a community medicine person with us who will tell you that possibly this will be wasteful. Even in the international studies, number needed to treat FD with H. pylori therapy is 14, and there epigastric pain syndrome responded more often, and I showed you Indian data. 10% are pure epigastric pain syndrome in India, and the 90% are postprandial distress syndrome or overlap with postprandial distress syndrome and epigastric pain syndrome, and they don't respond. Response to anti-H. pylori therapy may be related to antibiotic working against SIBO rather and gut microbiota dysbiosis rather than its action on H. pylori. Hence, I would say there is no debate. I would say that I'm sure my Dr. Usha will agree that it is too premature to say that we need to eradicate every H. pylori infected patient with functional dyspepsia in India currently, but we wait for more studies, and maybe in future we'll take a better decision, more informed decision. Thank you so much.
Thank you, Uday. I think that was also a very powerful argument describing the limitations of H. pylori eradication, especially in our country. Usha, you have just 1 minute for rebuttal, and then we can address some questions.
Yeah, thank you. I knew I had a very worthy opponent, but I was thinking that his case is actually weak. He has tried to put it up strongly, but if you put up all the components of the H. pylori is a bug which has to go. If you see it, you have to take it out. And all consensus documents suggest that we should look for it and eradicate it before we call it functional dyspepsia. The other point I want to make here is that dyspepsia is a very non-specific symptom. There are various components which cause these symptoms, including the diet of the patient and the lifestyle and the H. pylori and his inherent immune status. So obviously just taking out one bug will not take out everything. However, meta-analysis have shown that 33% reduction in the symptoms also happens with H. pylori treatment, and that takes about 6 months to 1 year. So that is your first benefit. The second is definitely a reduction in transmission in our country. And the third benefit is reduction in gastric cancer. So we do see a large number of gastric cancers which are young age patients, and 89% of the gastric cancer in the worldwide is attributed to H. pylori. So even if we save a few gastric cancer, we have done a great deal. I would still suggest that if you are doing an endoscopy in a patient with dyspepsia, you should take a biopsy for rapid urease test, and if it is positive, go ahead and treat that patient.
Thank you. Before we open the panel, there are few points that I think both the speakers should probably address. When we say H. pylori eradication, the first question is also how do you diagnose it? And I think the only practical method in our country is today endoscopy and rapid urease test, which means that if you are recommending H. pylori eradication, you're recommending doing endoscopy and biopsy to urease test for almost everybody. Yes, Usha?
Yeah, I would like to come in here. If you have alarm symptoms or patient is more than 50, then go ahead and do an endoscopy. However, the non-invasive way of diagnosis of H. pylori should be an order of the day in other sets of patients, the form of a stool antigen for H. pylori or a urea breath test. So I would suggest if you're doing endoscopy, do a rapid urease test. If you're not, if the patient, there is no indication for endoscopy, don't do an endoscopy to look for H. pylori. In that subset, do a stool antigen for H. pylori, which we routinely do in our patients in PGI and have decent pickup rates for these kind of H. pylori infection.
Yeah, the second point is I think we should be addressing the primary goal of treatment in the setting of this debate. Obviously, if you're looking at saying we're treating H. pylori to prevent gastric cancer, that's a totally different debate. So I think at least in the discussion part, let's try to focus on treating H. pylori for the main purpose of dyspeptic symptoms. Are we helping our patient, who have non-ulcer functional or whatever category of dyspepsia? Should that be the goal? Because once we talk about gastric cancer prevention, I think we need a different kind of evidence altogether. The third point I'd like to raise, which both the speakers have not addressed, is the efficacy of H. pylori eradication therapy in our country. We know the limitations, we know the widespread antibiotic resistance. Dr. Usha herself has promoted the resistance rates being high, efficacy rates coming down to even as low as 50 to 60%. We do not have the ideal 95% effective regimen right now available in our country. So that should also be taken into account. So could either both the panelists address these points?
Yeah, I agree.
I agree with you that actually because of short time that we have, but actually look at Dr. Piyush Ranjan's paper. Obviously, the eradication rate was to the tune of around 75%. Am I right, Dr. Piyush?
Yes, sir.
Yeah, so that means even I would say that was reasonably good. Many a time you'll realize that eradication is not high. Second issue is that there is a higher chance of recrudescence of infection or reinfection. Even Dr. Piyush's study, they talked about 15% reinfection or recrudescence of the infection. So you are very correct that when you are talking about prevention of gastric cancer, that is an entirely different subject. In fact, there are studies from China and also other countries which showed that just eradicating H. pylori is not the best method to prevent gastric cancer, because there are other factors which are important in carcinogenesis. But in FD patient in India, based on the current evidence, I reiterate, I say that this is a policy. If we make, then possibly it will be difficult to adopt that policy based on the evidence that we have. And nowadays we practice evidence-based.
Sir, Dr. Ghoshal, I would like to ask one question, and also to Dr. Usha Datta. So, sir, if you said that if we had a very effective drug for eradication of H. pylori, did you eradicate H. pylori in that case for everybody? Like we had lamivudine earlier, so we were using our patients for hepatitis B. Once we have effective drugs, probably our indications have widened. Number one. Number two, the Kyoto, what we talk of Kyoto, Maastricht, and Rome 4, H. pylori treatment is now a prerequisite for eradication of H. pylori is a prerequisite for diagnosing functional dyspepsia. And Kyoto also talks in detail about treating them early. Kyoto talks in detail about the age at infection, and you should be treating these patients before the onset of gastric atrophy and especially intestinal metaplasia.
Yes, I agree with you.
It is right. Yeah. See, let me answer to your question. Yes, I don't think that I agree that when we have 100% effective drug, we would eradicate H. pylori in everybody. We have much better job to do. We would like to prevent hepatitis B rather than H. pylori and prevention of gastric cancer. Based on the data that we have, out of 100,000 population, you have 10 gastric cancer in spite of a very high frequency of H. pylori infection. Second thing is that when Kyoto consensus was done, it was not related to functional dyspepsia. It was related to prevention of gastric carcinogenesis. That's why they are talking about early eradication so that intestinal metaplasia doesn't set in. Look at the Indian data. Indian data show that intestinal metaplasia frequency in India is much lower than in the West. And we know all the factors that prevent gastric cancer. It is not entirely genetic. Food is very, very important because turmeric prevent gastric cancer. Onion prevent gastric cancer. Fresh leafy vegetable prevent gastric cancer. Meat, which is particularly preserved, increases the risk of gastric cancer, and our dietary habit is different. And third thing, we have to say that even because of the high rate of reinfection, possibly eradicating H. pylori like US has done is not the priority for the country. Therefore, I would say that this consensus, which is for world, may not apply exactly to India. And there are many such things which world will adopt a policy. India will have to adopt a different policy.
I would like to, thanks Dr. Ghoshal. I would like to say, I would second what Piyush has said, that if we have a better drug, an easier drug, like a vonoprazole, amoxicillin combination, which is coming up, These are expensive, but maybe we may get a cheaper, more effective drug. And if we do get it, I'm sure we would like to eradicate H. pylori, eliminate H. pylori like hepatitis B and C. Nobody talked about hepatitis B and C elimination 20 years back, but now we are talking. So we should not also let the world go ahead and we be left behind, because then our country will never be a developed country if we continue to think like this. The second point I wanted to say is definitely there is symptom improvement, maybe the antibiotic effect, maybe the eradication, but definitely studies have shown that in the group where eradication has been established, they have more symptom improvement than the group which did not have eradication. The third point I wanted to say here is the aim here is not that you go to the community and start eradicating H. pylori, but the patient who's coming to you with GI symptom, he is having functional dyspepsia, there is gastritis. Eliminating H. pylori, which is a known cause of gastritis, is the best way to go ahead. So minimum the patient who's coming to you, knocking on your door, asking for relief of his symptom, you don't have any other cause which is well defined in these patients, you should eliminate H. pylori for the sake of the symptom, as well as for the sake of long-term reduction in complications, including gastric cancer.
Dr. Usha and Uday, could you please also address the question? Usha, you mentioned that H. pylori has been evolved with the human species over 100,000 years. So it's obviously serving a purpose. There must be some evolutionary advantage also to continue to carry H. pylori over all these generations. And we do know there are certain adverse effects of eradication in terms of increase in G-junction carcinoma, probably increase in reflux esophagitis. So should you take that also into consideration? Do you think just complete eradication of every patient with H. pylori will not have any consequences at all on the
that's right.
local and immunological effects?
Yeah, that's right. We have data which we published in American Journal of Gastroenterology, also published in Indian Journal of Gastroenterology, where we showed that if you have H. pylori, your severity of esophagitis is less. Your acid reflux into esophagus is less, because we all know that H. pylori in most patients does not do antral gastritis, rather it leads to pan-gastritis, and that reduces acid secretion. There are studies, like one study from Netherlands by Kuiper showed that if you eradicate H. pylori, there is a severity, increase in the severity of GERD, which is expected, because we all know G-junction adenocarcinoma has increased, or lower end esophageal adenocarcinoma has increased. In the West, in H. pylori frequency in the West is very low. GERD is a major problem to them. Barrett's is a major problem to them. Same is not true for India. I did not address another issue. See, apart from the dietary factor, even the infection with helminth modulate H. pylori induced inflammation. When somebody has helminth plus H. pylori, they actually have lower degree of gastritis, less intestinal metaplasia because of Th2 response. Now, what happens is, this is one of the reasons why we in India get much lower gastric cancer. And this has been shown in Colombia. This has been shown in Africa. There is a study by Paleo Korea. He looked at people who have helminth, who do not have helminth, and look at their gastritis, intestinal metaplasia, and they found there is a difference, because helminth causes Th2 response that reduces the degree of gastritis and intestinal metaplasia.
Dr. Shiva,
yes. Usha, we have a public health expert also on the panel. I would like him to respond, because this is a public policy. So Dr. Dilip Sharma, he is there. What is his policy? And in Nepal, what he will think about it. After listening the debate, what is his opinion from public health perspective? Dr. Sharma, is he there? One of the panelists?
Dr. Dilip, are you there?
Sir, he's logged out.
So then, Dr. Usha, you can continue. You were saying something.
Yeah, I was just responding to one of the questions which is here, that if you're doing an endoscopy, you should do a biopsy for H. pylori. That is a question from the audience. And second is, PPI also have anti-H. pylori effect. PPI has various effects on H. pylori. It suppresses H. pylori. It increases the H. pylori replicating rate, which allows the antibiotics to enter and damage the H. pylori. It also decreases the clarithromycin resistance. So those PPI has various effects on H. pylori. And there's a question about adding probiotics. I don't think we have, it is not sufficiently cost effective to add probiotics to the existing regime. It is important to give a tailored regime depending on your own antibiotic resistance.
But here I like to add, you see, yes, there are even multiple studies, including meta-analysis, in which one limb received eradication therapy alone, other limb received eradication therapy plus probiotic. We all know that 20% is the frequency of side effect when you give anti-H. pylori therapy, and the 5% side effect are so severe that it reduces compliance, the people stop the therapy. So when probiotic was added, both individual studies and meta-analysis showed it increases your compliance and therefore increases the eradication efficacy by the tune of 10 to 15%. So this is an important point mentioned here.
Yeah, Dr. Parimal, please.
I had one question for Dr. Usha. When you say you eradicate the H. pylori, what is your end point of defining eradication? So do you do a repeat stool antigen and after how many days?
The way to check for eradication is stool antigen or a urea breath test. So initially 2 weeks of anti-H. pylori therapy. In present day, we should give minimum 2 weeks of therapy. After that, continue with another 2 weeks of PPI. Then 2 weeks, no medication, no PPI. And then minimum 2 weeks of PPI, and 4 weeks after the last antibiotic dose, you should check for H. pylori, either by a urea breath test or a stool antigen test. You should not repeat an endoscopy for that same purpose unless there was a gastric ulcer to start with, because of which you started the anti-H. pylori therapy. Otherwise, in a patient with functional dyspepsia, if you are eradicating, test with stool antigen at the end of 8 weeks of your therapy start.
And the other question is, we have been using the clarithromycin amoxicillin PPI treatment for 14 days. And recently, when we had people who were stool antigen positive, like you described, we tried using the Bismuth regimen because it is now available in India. So what is your experience on that regimen?
Yeah, very important question in India, because we have we may have a high clarithromycin resistance in our country because of a lot of use of these kind of drugs. So I have started adding amoxicillin 1 gram twice a day, clarithromycin 500 BD. To that, I have been adding Bismuth. And I use PPI, which is either esomeprazole or rabiprazole, because they have the maximum efficacy amongst the PPI which we have. Vonoprazole has more efficacy than this. So addition of Bismuth, the eradication rate seems to be more. And that is what studies show, that we should use Bismuth in situations where you have suspected high resistance to H. pylori.
I think we'll have to stop here. The time's up. I know there are a lot of points that can still be discussed, and this is a interesting point, interesting topic, and which definitely practices polarize. There are people who would eradicate widely and people who would be refraining from eradicating unless it's clearly, strongly indicated. And we've got a lot of information presented from both sides, Dr. Usha and Uday, who are giant titans in the field. Thank you. Yes, Usha?
Yeah, I just want to leave it with the one last question. If any gastroenterologist is H. pylori positive, will he treat himself or not?
The question is, would you test for yourself or not? That's more important. If I was getting an endoscopy done, I would ask not to be tested for H. pylori, I think.
Yeah.
Okay, thank you. Thank you, everybody. I think that was a very good discussion and very fruitful. And thanks to Gangaram team for this topic and for this opportunity. Over to Ashish.
Thank you, Dr. Siva Prasad.
Final word from Dr. Anup. What will you do, sir?
Dr. Anup.
Anup, what is your final take?
Yeah, I have my own opinion. In fact,
we are asking your opinion.
I will not eradicate H. pylori.
Okay. Thank you.
Okay.
Thank you, Dr. Anup. Thank you, Dr. Siva Prasad, for this interesting debate. We could have gone on for hours but we have to move on. And for the next session, which is on IgG4 related diseases of the digestive system, I would like to invite our moderators, Dr. Saeed Hamid from Pakistan, Dr. MS Khuru, and Dr. Manu Tandon. Dr. Saeed Hamid is a professor in the Department of Medicine and director of the Clinical Trials Unit at the Aga Khan University, Karachi. And he was the formerly chair and Department of Medicine he was at UK and at many other places. Dr. MS Khuru was the formerly director at the Sher Kashmir Institute of Medical Sciences at Srinagar, and Dr. Manu Tandon is a consultant gastroenterologist at the Asian Institute of Gastroenterology. So over to you, Dr. Manu Tandon. Would you like to introduce the speaker and start the session?
Thank you, Ashish. I think I'd like to thank your entire team. Anil is also there. I saw him a little time back for this privilege. I have got two very learned moderators with me and they will take up the questions. Well, introductions are going to be brief because we'd rather concentrate on the subject. Dr. Sanjay Satpathy is the professor of medicine at the North Shore University Hospital, New York. He is very well known in the field of liver diseases with over 130 papers. He is the editor-in-chief of Translational Research, Gastroenterology and Hepatology, as well as the chair of the education committee of the ASLD. He would be talking to us, as Ashish has already pointed out, on IgG4 related diseases. Very briefly, I'll talk about my panelists. We'll begin with our international expert, Dr. Amna Bhatt, who's also from the Aga Khan University, Karachi at Pakistan, General Secretary of the Pakistan Society of Liver Disease. Dr. Biliary, teacher to many of us here and in UK, does not need any introductions. Dr. Sunil Taneja, Consultant, Department of Hepatology at Chandigarh, PGI. Manas is at the AIMS Bhubaneswar, a rising star in this subject. And Dr. Naresh Bansal is a well-known consultant in Delhi, mainly at the Gangaram Group. With these few words, I'd request Dr. Sanjay to please take over the stage for his talk.
So thank you for that introduction. I would like to take this opportunity to thank Professor Anil Arora for the invitation, and I'm glad to be here among this esteemed audience. Let me share my screen. Is my screen visible?
Yes, you can go ahead.
All right, great. So I've been assigned to talk about IgG4 related diseases of the digestive system. So IgG4 related disease is increasingly recognized entity more recently. And as you can see on this slide, it affects multiple organs, either in isolation or as a multiple organ involvement. This can happen synchronously or metachronously as well. Today, my focus will be the GI-related diseases that will include pancreas, liver, biliary tract predominantly, but also I will talk about involvement of the esophagus, stomach, small bowel, and the colon to some extent as well. So having said that, examination of multiple organs is important when you have signs and symptoms of IgG4 related disease. And this is just to give an overview of what investigations you could potentially need to do when there is a suspicion of this IgG4 related diseases. This is a predominantly, slightly male predominated disease, although it's pretty much affects both gender, but the slight male predominant. But this does not help a lot the gender in terms of diagnosis of IgG4 related diseases. The Boston consensus criteria is the criteria that has been widely used for diagnosing IgG4 related diseases that can be extrapolated to different organs. I'm exemplifying this on the liver itself. So the so-called criteria describe three principal histologic and a couple of additional minor criteria for the diagnosis of IgG4 related diseases. Usually, a diagnosis requires at least 2 out of the 3 major criteria. And in addition, histologic findings and 2 principal supporting immunohistochemistry findings are also described. So let me point out this, the major findings which I'll be talking over and over again during my lecture. The main findings are the dense lymphoplasmacytic infiltrate, fibrosis that is arranged at least focally in a storiform pattern. It's like a cartwheel pattern that you can see here in this particular diagram. And obliterative phlebitis, which is essentially expansion of the lymphoplasmacytic infiltrates into the lumen of the vein mostly, and sometimes arteries are affected, but primarily is the phlebitis, and almost squeezing the lumen into a slit here. So these are the 3 major criteria, out of which 2 out of 3 is important in the diagnosis. Additional findings that either neither sensitive nor specific are phlebitis that does not obliterate the lumen, and increased eosinophilic numbers. The supportive findings, in addition to the major criteria we talked about, are the 2 principal supporting immunohistochemistry findings are described as elevated IgG4 positive cells, and the ratio of IgG4 to IgG ratio greater than 40%, that is more than 0.4. So with that, I want to just touch a little bit on the pathophysiology. So what we found, there was a fibrotic lesion, and there are mass-like lesions that we see in different organs. So these fibrotic lesions in IgG4 related diseases probably the result of an interchange between the activated B cells and the CD4 positive cytotoxic T lymphocytes and M2 macrophages and fibroblasts. The way it's happening here is this activated T cells, the activated B cells, they migrate to the inflamed tissues, and they present the antigen to the activated CD4 T cells, promoting their expansion into CD4 positive cytotoxic T cells. Now, these clonally expanded CD4 positive CTLs that target cells, the target cells within the inflammatory milieu of the lesions, then induce apoptosis by cell death by releasing perforin or granzyme. So, and this then this by the transforming growth TGF beta activated M2 macrophages, then they clear this apoptotic cells by efferocytolysis. Now, this M2 macrophages releases IL-10, CCL18, and IL-33, and these activated B cells releases PDGF. All these things leads to activation of the fibroblast. It also is supported by the CD4 positive CTL cells by IL-1, beta, TGF beta, and interferon gamma. All these things lead to activation of the fibroblast. And these fibroblasts, once activated, they release extracellular matrix proteins and they fill the potential space that is generated by the apoptotic cells. And this leads to what? A clinical manifestation of tumor-like soft tissue mass and organ enlargement. It also leads to the characteristic histopathology, which is the lymphoplasmacytic infiltrate and the storiform fibrosis. So this overview also gives us ability to treat these patients, especially with the rituximab. When you eliminate these CD20 positive B cells, it leads to a reduction of the cytotoxic CD4 T cells and improvement potentially of the fibrosis through the TGF beta and IL-1 beta reduction. I'm going to focus now system by system. We'll talk about IgG4 related hepatobiliary diseases at the first. The IgG4 related liver disease, grossly the disease may mimic a bile duct carcinoma with thickening of the bile duct as well as expansion and fibrosis at the porta hepatis. Less commonly, a well-circumscribed intrahepatic mass may be identified. And as pointed out here is one of the explanted specimen on histologic evaluation. There is a 6 centimeter mass lesion that showed pathologic features of the IgG4 sclerosing cholangitis. This is actually more recently being called as IgG4 sclerosing cholangitis. The disease was confined to the liver, and the hepatic hilar involvement was not identified in this particular case. And in the right side, you see the histopathology showing the involvement of the hepatic hilum and the 2 fairly well circumscribed fibroinflammatory lesions. Similar nodules, albeit somewhat smaller, may also be detected in the peripheral portions of the liver as well. But usually their locations is in the hilum and perihilar region. This is showing a low power view, showing the expansile fibro-inflammatory lesion involving secondary branches of the biliary tree. In addition, note the portal tracts seems to be expanded. And what you see on the right side, the bile duct in this image is surrounded by dense lymphoplasmacytic infiltrate. Stellate separated narrowing of the bile duct, a feature also seen in type 1 autoimmune pancreatitis, is common feature of IgG4 sclerosing cholangitis. Also note one thing, that the biliary epithelium appears to be preserved. I will come back to this. The preserved biliary epithelium also portends a problem in our diagnosis by endoscopic or biopsies. So this is another picture showing IgG4 related sclerosing cholangitis. What you're seeing here, the portal tract is expanded by predominantly lymphocytic infiltrate with interface activity. And there is also increased number of IgG4 plasma cells on the immunohistochemistry. These features are by themselves are not diagnostic, but and would not definitively distinguish from IgG4 related disease from PSC, because sometimes you can have overlapping findings as well. So the involvement of the bile duct creates a highly characteristic histologic appearance. The most reliable feature is the presence of a full thickness, uniformly dense inflammatory infiltrate. So this, I want to point out here that the involvement of this dense inflammatory infiltrate is away from this epithelium, is outside into the full thickness wall. And this involvement of the outer half of the biliary wall is particularly characteristic of with the obliterative phlebitis and storiform fibrosis type of lesion that we normally see in IgG4 related disease. The lining epithelium is generally intact, and although the presence of a stent sometimes could precipitate extensive loss of epithelium, but usually the lining epithelium is intact and may give you an opportunity for the diagnosis. Now, again, this is showing another MRI images on the left side in IgG4 cholangiopathy, which you're seeing stenosis close to the hilum with evidence of inflammatory pseudotumor. And on the right side, you're seeing the US picture, endoscopic ultrasound showing circular, which is circular thickening with the distal common hepatic duct stenosis. So the wall is thickened. You can see this on these endoscopic ultrasound images. Now, so this actually creates a problem when you do an endoscopic biopsies. When you're doing a spyglass cholangiography, the biopsies are number one small, and also can be fraught with the cross artifact. And the full thickness biopsy is not possible. So our reliance mostly is based on the serum IgG4 and IgG plus IgG ratio. Plus, sometimes what is helpful is by taking a biopsy from the ampullary region many times. And the ampullary biopsy is quite sensitive. The ampullary biopsy, one thing I want to tell you, is not is actually devoid of the classic feature of the storiform fibrosis. That essentially not affected. What you see is only the IgG4 positive cells in the ampullary region that will help in the diagnosis. Usually more than 10 per high power field, and sometimes the ratio of the IgG4 to IgG positive ratio more than 40%. Those things are mostly helpful in the diagnosis in the ampullary biopsy. And here is showing many studies quoting the different sensitivity and specificity of the ampullary biopsy, which is ranging from 52% to 80% sensitivity, and specificity is quite high. And more the IgG4 positive cell, the specificity goes higher. Now, the IgG4 related cholangiopathy has been divided into different types, type 1 through type 4. The type 1, usually you see a lower CVD stricture frequently associated with autoimmune pancreatitis. Type 2 is a diffuse intrahepatic cholangiopathy and a lower CVD stricture. And type 3 is hilar and lower CVD stricture, and type 4 is hilar stricture alone. This has implications in the management. Why is that? Because if you talk about the lesion and the type 1, your differential diagnosis will be bile duct cancer, chronic pancreatitis, and here an intraductal ultrasound, an US FNA of the pancreas, and biopsy bile duct could potentially help in diagnosing these patients. In the type 2 and type 3, which is usually the differential diagnosis is PSC. And here a liver biopsy could be helpful if you're lucky enough to see a onion skinning lesion. That could help to differentiate from PSC. And colonoscopy, because these patients would have, particularly PSC patients, are more likely to have IBD, and those things can be helpful in the diagnosis. And other supporting findings in organs, other organ involvement would help in IgG4 related disease, along with an IgG4 level and the ratios. The type 3 and type 4, the bile duct cancer and gallbladder cancer would come in the differential diagnosis. And again, US intraductal ultrasound biopsy the bile ducts will be helpful in differentiating. So these types of classifications are important, especially to differentiate this differential diagnosis. I want to point out some of the important findings that may differentiate PSC from IgG-related sclerosing cholangitis. Age of presentations, PSC patients are a little younger usually. It's not that IgG4-related sclerosing cholangitis is uncommon in the younger age, but usually they're more older patients. There is no difference. The male, again, male patients are more likely again here, and that doesn't help. But what is you see in cholangiographic appearance, thickening the bile duct walls and long strictures in the IgG4 related with upstream dilatations. But in the PSC, you will see like beads on a string appearance where bile ducts with a short segment structure interspersed with normal caliber or dilated segments. Other organ involvements are passed in IgG4 related sclerosing cholangitis, you find it, and PSC, you find the IBD. And the level of IgG4 more than 140 is classically helpful in the diagnosis, which is quite common in the IgG4 related disease. Histology, as I said earlier, onion skinning, periductal fibrosis, more likely helpful in PSC, but it is also seen in small percentages cases of the IgG4-related sclerosing cholangitis, so it's not entirely helpful. And the immunohistochemistry particularly is helpful by looking into in the biopsy, especially when more than 10 IgG4 positive cells per high power fill and the ratio more than 0.4. And the other thing is the response to steroid or immunosuppressive therapy, quite swept in the IgG4-related sclerosing cholangitis, but minimal response in PSC patients. So that is a diagnostic algorithm the Japanese society has come out with. And basically when there is an organ manifestations and you will look for the IgG4 level of more than 135, this is essentially for all IgG4-related disease, but can be extrapolated to liver or any particular organ as well. So, and when it's more than 135, it's yes, you do biopsy and you find the biopsy, the ratio more than 40% or IgG4 positive plasma cells more than 10 per high power fill, it is yes, then it's definitive and go from there. But if it is yes, and there are other findings are probable based on other atypical features, then you have to go by the organ specific criteria. But if you have the levels are low and this the ratios are not there and the IgG4 levels are not elevated, you pretty much exclude those diagnoses. The other important thing is you have to resort to the criteria of HISORT, which is the 5 cardinal diagnostic features that you can look for. This is particularly I'm talking about in the liver and in the with the IgG4 sclerosing cholangitis, and you can see you have to go by histology, imaging, serology, and other organ involvement and response to immunosuppressive therapy, and clinical, biochemical, and cholangiographic improvement within about 4 to 6 weeks after starting steroids. This 5 cardinal diagnostic features with the steroid responsiveness usually makes the diagnosis much easier. Now I'll switch a gear a little bit to IgG4-related autoimmune hepatitis. This is a classic picture of a patient with the IgG4-AIH where we're seeing lobular inflammation with the journal to breathing necrosis, then fibrotic septa showing inflammatory infiltrate consisting of lymphocytes, plasma cells, and eosinophils, and the enlarged portal tract showing inflammatory infiltrate with interface activity, and the hepatocytes are trapped in the fibrous septa, and IgG4 immunostaining positive. Well, these things are not classic for autoimmune hepatitis. So, there is so much overlap in it. So many times autoimmune hepatitis are misclassified, and IgG4 autoimmune hepatitis misclassified as just autoimmune hepatitis as well. So this is just with this histology, it is very difficult to completely distinguish, although IgG4 positive cells in the immunostaining, with the immunostaining will be particularly very helpful. And this is kind of quite clear on this kind of as meta-analysis or a review of the different studies that was published in this review, where I think one of the study was from India, from Dr. Amar Parakar as well. So there are a lot of studies from different regions. And what you can see here is these studies actually look into different criteria by looking into either more than 5 IgG4 cells per high power field to more than 10. So there are some variations because there was no standard criteria, and these are things evolved over time. But with that, with having said that, the number of patients they find is about, it's a range with the IgG4-AIH range from 3.3% to 36% in their patients with autoimmune hepatitis group. And the differences between the liver enzymes or liver biochemistry is not that classic to help or be helpful. IgG4 levels, some of these studies, they didn't find a lot of a difference in the serum itself, but the histopathology, there are some increased lobular and plasma, lobular hepatitis and plasma cell infiltrate. But then again, some studies are showing no difference as well. So this histopathology, what I'm seeing is not that helpful in terms of differentiating. So what is more important is the IgG4 positive cells per high power field on immunohistochemistry is primarily more helpful in the diagnosis. So the proposed diagnostic criteria that has been proposed by the Japanese Society is as follows here for autoimmune hepatitis from IgG4 related AIH. Serum IgG4 level more than 135, increased IgG4 positive cells in the liver tissue with more than 10 per high power field, chronic hepatitis with journal and bridging necrosis or broad collapse, and metachronous or synchronous association of other IgG4 related diseases. So when you have the definite IgG4 related AIH, when you have all 4 present, probable when there were 3 of them are present, 1, 2, and 3, and possible when any 2 conditions. So this is helpful in at least to guide us into diagnosing IgG4 related autoimmune hepatitis. And this case particularly exemplifies a relationship between association of AIH with or IgG4 related autoimmune hepatitis with other IgG4 related diseases, such as in a particular patient here is an autoimmune pancreatitis. This case exemplifies the different flare of autoimmune pancreatitis and AIH and their association at the same time. And what they have shown over a period from 2003 to 2013, this patient has episodes, initial presentation was autoimmune hepatitis. And you have elevated ALT, IgG4 and IgG levels, and that classified to the diagnosis of IgG4 related AIH. Later, this patient developed pancreatitis and again responded to it. And again, with the flare, there was an ALT elevation at the same time as AIP as well. So this raises the question, should IgG4 AIH be considered as a subtype of AIH or as a hepatic involvement of systemic IgG4 related diseases? I think I'll list this question for our discussion. Now, imaging an autoimmune pancreatitis, I'll go to the next one. What you see classically is a sausage-shaped swollen pancreas with the main finding in this particular MRI, which is classic of these patients. And the MRCP shows the AIP typical variations in the caliber of the pancreatic duct and post-stenotic dilatation, and with a classic double duct sign, localized stenosis with both bile duct and the pancreatic duct. So the AIP, autoimmune pancreatitis, the international consensus diagnostic criteria for autoimmune pancreatitis, they came out with the guidelines. So essentially they designed 2 criteria, level 1 and level 2. Each has its own parenchymal imaging, ductal imaging, serology with other organ involvement, and histology appearance. I'm not going to go through all the details for the interest of time, but just suffice to say that we have these 5 criteria, P, D, S, and H, which is parenchymal imaging, ductal imaging, serology, and histology of the pancreas. The histology is usually classic, and at least 3 of the following: periductal lymphoplasmacytic infiltrate without granulocyte infiltration, obliterative phlebitis, story from fibrosis, and more than 10 per high powered field of IgG4 positive cells, which is classic we talked about earlier. So this, but the level 2, when there is little atypical findings, that goes down to the level 2 route. Now, with that being said, if the patient presents with an AIP and presenting with obstructive jaundice or pancreatic enlargement, and you have a classic level 1 type of parenchymal findings, and you review the imaging, IgG4 levels, an ampullary biopsy that's suggestive. Yes, you don't have to do any pancreatic biopsies here. And classically, these patients can be treated with a steroid. And if your response, yes, then the diagnosis is confirmed. If they're not, then you have to follow the type 2 AIP, which I'll go in a second. So if the patient otherwise presents with a pancreatic mass, then you go to the same route, but you may need a biopsy of the pancreas. And the biopsy is suggestive, then you go for it. It's a definitive AIP. If the biopsy is inconclusive and there is a mass lesion, sometimes they need a surgical resection and maybe you need a diagnosis in those cases. Sometimes you're not available in conclusive, then you go for a steroid trial. And if they respond, you consider the diagnosis. And the steroid trial fails, you reconsider it. And again, there is the type 2 AIP, again, a similar route. Again, not going through the details, but again, this is the more difficult scenario in the type 2 AIPs especially. But if you have a pancreatic core biopsy that is quite suggestive, you make the diagnosis. Otherwise, you go through a number of steps, which I don't want to go through right now, but for the interest of time, and I have this reference here, you can go through this one. But I want to suffice to say the difference between the type 1 and type 2 AIP. So what usually they have shared criteria in both type 1 and type 2. They have the periductal lymphoplasmacytic infiltrate and inflammatory cell-rich stroma, which is similar in type 1, type 2. But what you see more commonly in type 1 AIP, the storiform fibrosis is pretty prominent, and the IgG4 positive cells are more than 10 per high power field, more likely in type 1 AIP, which is less noticeable in the type 2 AIP. And the other findings are not that important, but this is actually just a difference between type 1 and type 2 AIP overall. And the other thing very important in type 2 AIP is that there is more association with inflammatory bowel disease, and the type 1s are more strictly associated with other organ involvements, including retroperitoneal fibrosis and tubulointerstitial nephritis and many others. So finally, we'll move on to some of the luminal scenarios. IgG4 related sclerosing esophagitis. This is a patient who presented with dysphagia or dinophagia, and endoscopy, this published in GI Endoscopy is a case report, but they found stricture with inflammatory exudate there. And that has, with the second endoscopy, has progressed over time. This is the varium swallow showing diffuse irregular luminal narrowing with several ulcerations in the mid to lower esophagus. And then this patient, unfortunately, because of the inconclusive diagnosis, this patient underwent a resection, and the resected specimen, what you're seeing is showing transmural fibrosis inflammation with lymphoid follicles, and there is diffuse infiltrations of lymphoplasma cells and eosinophils with stromal sclerosis. And as you see in the bottom, you're seeing the dense infiltration of IgG4 positive plasma cells. So this was a difficult diagnosis, especially can pose challenges in your clinical practice and may lead to even to a complete surgery and resection. But the authors think that potentially this could have been avoided by giving a steroid trial. It would have made a diagnosis earlier. There are cases with a gastric IgG4 related autoimmune fibrosclerosing pseudotumor. This is a patient who had an endoscopy with a large polypoid mass in the gastric midbody. The CT scan also shows that. And then when they took it out, they find IgG4 immunohistochemistry demonstrating IgG4 positive plasma cells. So this kind of presentation is possible as well. This is another very important case report that was presented. I think we all see similar cases in our clinical practice as well, published in American Journal of Gastroenterology. There's a 62-year-old man who presented with a 2-month history of epigastric pain, underwent an EZD, which showed gastric fundal varices without any signs of bleeding. Then they did a CT scan, which is showing a 14 centimeter mesenteric mass extending along the mesentery, involving the supramesenteric artery, splenic vein artery, inferior mesenteric vein and artery. So, and this patient's immunoglobulin level was elevated to 179, and the endoscopic ultrasound guided needle aspiration confirmed IgG4 related sclerosing mesenteritis. The patient was treated with prednisone 30 milligram a day and tapered over 24 weeks to 5 milligram a day, and the gastric varices disappeared, and marked improvement in mesenteric mass was confirmed on a CT scan. So I think this kind of diagnosis is so important because we can make a big difference in these patients' life. But one thing I want to say, that sometimes you have a confusing, conflicting
Satpathy,
diagnosis.
we'll hurry up the other slides if you don't mind.
Yes. So I will, in the neuroendocrine tumor sometimes can confuse because they have dense fibrosis. And finally, colonic lesions are also possible. And again, for the interest of time, I'll skip this, but you do find this kind of lesions as well. Finally, the treatment of this IgG4 related disease, according to the Japanese guideline, is induction therapy with 30 to 40 milligram per day. And then you taper it over the next 3 months and then continue with 5 milligram per day and remission and maintenance therapy and follow up, and these patients do well with that. And that's my summary. So IgG4 related hepatobiliary diseases are part of a systemic fibroinflammatory conditions termed as IgG4 related disease. Hepatobiliary diseases can present with abnormal liver chemistry, biliary stricture, impending differentiation from other benign and malignant hepatobiliary disorders are kind of very difficult and sometimes creates a lot of challenges. And multiple organs, as I said, are involved. And the diagnosis is based on a combination of clinical, biochemical, radiological, and histologic findings. These patients respond to steroid very well and should be treated that way. I will conclude with that. And thank you very much for the opportunity and take some questions.
Thank you, Dr. Satpathy. That was a wonderful overview. We enjoyed your lecture, and I'd request my co-moderators, Dr. Kuru and Dr. Hamid, to please take up the questioning. We can go ahead and ask Dr. Satpathy to take up the questions that have been put up.
Does Dr. Kuru want to start or shall I start? Dr. Kuru, where are you?
You can start, Dr. Hamid. Yes, either way.
I think Hamid, you should start. Go ahead.
Okay. Well, thank you very much for the talk. It was very nice, a good summary of everything. My question to you, Dr. Satpathy, is on the diagnosis. I think that is where we have the biggest problem. What is the sensitivity and the specificity of the IgG4 test, which is the one that is most widely used? I like your emphasis on the biopsy material and the biopsy findings and the features which sort of facilitate the diagnosis. But quite often we find in our practices now that people are doing IgG4 levels and just making, in many cases, a presumptive diagnosis and starting the treatment with steroids because it is a very steroid responsive disease. But then you really wonder whether this is good practice or not. So I would want to put you on the spot to say what is the sensitivity and specificity of IgG4 levels and how much is the need for a biopsy in our clinical practices. Over to you.
That's a wonderful question, actually. Well, serum IgG4 level concentrations are normal in approximately 10 to 40% of the patients with IgG4 related disease. So that makes a diagnostic challenge. But a normal serum IgG4 does not exclude a diagnosis of IgG4 related disease. However, if you look at one of the European cohort, serum IgG4 greater than 1.4 gram per deciliter, like 140, had a 90% sensitivity, 85% specificity, and a 59% positive predictive value in the diagnosis of IgG4 sclerosing cholangitis over PSC patients. For serum IgG4 higher than that, more than 2.8, there is a 70% sensitivity and 98% specificity. So as the level of the IgG4 is higher, your specificity goes up, but the sensitivity goes down. So usually that's why most these guidelines has zeroed on more than 1.4 or 140 milligram per deciliter as the cutoff, where the sensitivity is 90% and the specificity is 85%.
Okay, thank you. Dr. Kuru.
Very interesting talk, Dr. Satpathy, and you made us very wise on a protein manifestation of a very interesting disease. I was just asking two important questions. One, how common you see it in US, and because most of the studies you talked about in Japan, we see this disease, we think of this disease, but see few cases here and there. And second thing is, what's the role of the imaging, particularly MR and US, how good they are in really picking up specific lesions, particularly of the pancreas and the bile duct. What is their role? And do you really suspect them by a specific manifestations? To you, Dr. Satapathy.
Yes, the recognition of this entity IgG4 related disease, if I go back in my 10 years, I was not even aware at some point, like when we started learning like case reports. And over this time, when we have been seeing more and more, and this entity is becoming more recognized. In my clinical practice, I have seen not more than 10 cases of IgG4 related diseases. And the couple of cases are very interesting that I have seen. One patient who has an HIV came in with a mass, huge mass in the right lobe of the liver, and we did an US guided biopsy of this one. It was non-diagnostic, so it just came out inflammatory exudates. Then we thought maybe the diagnostic samples was a problem. We repeated a biopsy and a CT guided biopsy, and the biopsy again showed similar findings. At that point, the patient lost to follow-up for a month and went to his primary care physicians, was given antibiotics and some treatment with a steroid. And this patient came with significant improvement symptoms. A repeat scan at that point now showing a reduction of the size of the mass. And so after further review, we went back and we found this patient has IgG4 related liver mass. And this has been followed for now 6 months, and his mass is reducing and in size over time. So I think these entities are rare, but certainly something that we must consider on differential diagnosis. In terms of the diagnosis, we have criteria based on, as I outlined, the Boston consensus criteria pretty helpful in terms of the diagnosis, where the biopsy at this time is necessary in order to make a complete diagnosis. Other are supportive, and IgG4 levels will be very helpful in these patients.
I think we got a very interesting panelist, Dr. Jung Biliary. You want to make a comment on this presentation? We have Jung in the audience.
Yes.
Okay.
Sanjay, I enjoyed your talk very much. And I always thought was IgG4 related diseases were rare and is still rare. And we grew up with autoimmune pancreatitis when we first come to this entity, IgG4 related disease. Autoimmune pancreatitis was very sort of fashionable diagnosis to make at that time. But now with your talk, it's becoming really very confused. Different criteria, different imaging, and all that thing is becoming now very, very confusing in the sense that it has been in any disease in the body where there will be differential diagnosis IgG4 related disease. So the diagnosis becomes difficult because you need a tissue diagnosis. You said IgG4 level, unless they're more than 140, is not very diagnostic. Then and you cannot start with steroid trial in any patient you think it is an IgG4 related. It has to be a tissue-based diagnosis. So obtaining tissue is very difficult. So how do you go about this problem?
I think this is the limitation of this particular disease, which is mostly tissue-based diagnosis. And most of the other diagnosis, when you're talking about, the good thing about the IgG4 related disease is the rare disease. And when you have a diagnostic dilemma, then only you are investigating further, and the tissue is important to make a diagnosis. I don't think we have a better way, unless we have a serum level of IgG4, which is high, that will be supportive, and you can avoid a tissue, especially in type 1 autoimmune pancreatitis I'm talking about. When you have all the classic features are there, you don't have a biopsy, and other organ involvement is, you have another organ involvement, or like Mikulicz disease, or some other organ involvement, and that can support your diagnosis, and you can avoid a tissue and make a steroid trial to make a clinical diagnosis.
Thank you.
Dr. Amna had a few questions, Dr. Biliary. I'll ask her to put it forward directly to Dr. Sanjay. Dr. Amna, you had put up a few questions.
Thank you very much.
Yeah.
Yeah.
Yeah, please.
Thank you very much. So wonderful presentation, Professor Sanjay. So there were a couple of questions like one by one. So for the first two questions is, what is your opinion? Is this a rare disease or this is underdiagnosed? And the second question is about IgG4 levels. So the various labs and few labs do report upper normal limit higher than 135. So is this level of 135 is applicable for all of such situation and other different?
So I think your voice not coming very clear, but
Yeah,
I understood
the question
correctly.
was, is 135 absolute cutoff, because different levels give different, different labs give different levels. So she wants a clarification on that.
Well, the consensus criteria has mostly zeroed on 135 or 140 in different criteria. So I will go with those criteria-based levels. Unless your own laboratory has come out with a criteria, which is very unlikely, you will have come out with a criteria based on a particular level to diagnose IgG4-related sclerosing cholangitis. I doubt that's going to be the case. So you probably have to go with that criteria, the level of 135 or more than 140 milligram per deciliter.
Can I comment, Dr. Tandon?
Yeah, please go ahead. It's open to everyone, Anil.
Answering the query of Dr. Jung Biliary, if you look at the all autoimmune diseases, the problem is making a correct diagnosis, because this is the only pathological entity in which you have a constellation of possible, probable, and definitive diagnosis. If you look at the diagnosis of autoimmune hepatitis, also 50% of the time serology may be negative, and liver biopsy also may not be conclusive, especially if the person is taking DILI. And hence you have to have a combination of either possible, probable, or definitive diagnosis. Exactly same thing happens in patients with autoimmune related IgG4 related diseases. The beauty of these diseases is they are difficult to diagnose because of the limitations of IgG level, as very correctly put by Dr. Amna. 140, see, the normal values in our lab is up to 200. So a 2 times upper limit of the normal is something which is highly suggestive of elevated IgG level. Every lab reports differently. So a 135 cutoff would mean a more than 2 times the rise in the level. The beauty of the autoimmune diseases is that it is absolutely treatable. So whenever you have multiplicity of the problems like extra pancreatic or extra hepatic manifestation, and when you have concomitant involvement of the other organ in absence of a positive histology, if you have a high index of suspicion, this is something which gives you good results if you give a trial of steroids.
Can I ask one question?
Yes, go ahead.
So very interesting talk. I have two questions for you. One, is there a genetic basis for this disease? Because there are so many organs which can be involved. If yes, then what are the precipitants and triggers for this disease? My second question is related to IgG4 related AIH, autoimmune hepatitis. So where do you suspect IgG4 related AIH, and is there a different protocol of treatment for IgG4 related AIH, or it's the same?
Yes, two very interesting questions. Unfortunately, there is the genetic basis is still being explored. We do not have we don't have enough knowledge at this time to suggest that the genetic basis. And the second question, with regards to the autoimmune hepatitis, now the treatments for IgG4 related disease are all pretty much similar. It's it can be extrapolated from one type of disease to the other type of the disease. So basically, the last slide that I showed is all the similar. So you start with the steroid, and sometimes rituximab can also be used as a second line option or even as a first line option as well. But mostly because it's most commonly less side effect, and so mostly we use a steroid as the trial with 30 to 40 milligram as an induction, and these patients respond pretty well if they are IgG4 related sclerosing cholangitis or autoimmune hepatitis or some other related diseases as well.
So then why are we trying to diagnose IgG4 related AIH if the treatment remains the same?
I think it's important because you raise an important question, but I think it's important to know what we're treating, whether it's an autoimmune, even if the response is similar, the distinction because the long-term, the relapses after the treatments, these patients are quite common. I don't know how, because the disease is rare, and the autoimmune hepatitis, the conditions are rare. We don't know their long-term outcomes and how many of them will relapse. And so I think this is still an evolving entity. As I said, this is, I think, a lot more to learn over time, because what my understanding is that the IgG4 related autoimmune hepatitis tend to relapse more commonly, but again, they respond like autoimmune hepatitis, they respond pretty well. The question is what percentages will relapse and what percentages will stay in remission. We do not know that. I think these are situations that I think our knowledge is evolving in a way at this point.
Thank you.
Manu, another question. Manu, can I ask a question?
Please, but I'd like my other two moderators also
Manu,
after you to make a comment.
What is why differentiate type 1 and type 2 autoimmune pancreatitis when the treatment remains the same?
I think the distinction is because the type 2 autoimmune pancreatitis do not show these classic features that is easy to diagnose with the autoimmune pancreatitis, because they don't have the IgG4 levels that are elevated. So the treatment, it's the most of a diagnostic dilemma, and the response to treatment is the same. But knowing whether it's an AIP or not is the type 2 AIP is going to pose a challenge to us, and that's why the distinction is.
Dr. Manas and Dr. Naresh, any comments from you? And I'll take just
Yes,
one question because I think we have overshot
Yes,
our
sir.
time.
One
Manas?
comment from my side.
Yes.
So I have a little bit of experience on this IgG4 related hepatitis and cholangitis. So when to suspect IgG4 hepatitis? Basically, we can suspect when there is seronegative hepatitis, is a seronegative autoimmune hepatitis. In that group, we can ask our pathology colleague to put an IgG4, ISC to put for IgG4, and we can send IgG4 level also. And secondly, sir, regarding IgG4 cholangitis, recently we have published in Indian Journal of Gastroenterology. This age is a difficult game. Usually the literature says that it is fine in 5th or 6th decade, but in our experience recently we have published 2 cases where they are present in 2nd decade only. One boy is 16-year-old, IgG4 cholangitis. And yes, of course, as our moderators and all the panelists have mentioned, tissue is an issue here. But it is very rare disease and it is very responsive to steroid. And both the children that is less than 20 years, they respond very well. They are imaging and all those things received within 4 weeks or 6 weeks of starting steroid. So suspicion is to suspect this disease is the key. And really this is responsive disease and we can have a greater impact on the patient life. Thank you.
Dr. Satpathy, very well presented. My question is very basic. Like we have 4 subclasses of IgG, IgG 1, 2, 3, 4, but we have IgG4 disease only. So what is the wrong with IgG4? Because they are almost 90% similar in their amino acid structure. So
yes, so the significance of the IgG4 is not clear, but what we have known from this IgG4 related disease is that the IgG4 antibody is particularly pathogenic to the epithelial cells antigen, some epithelial structures. Most of the disease are confined to the epithelium. These are kind of an epithelium burn disease, I'll say. So they don't know which one it targets, like on the epithelium, which is mostly they're saying carbonic anhydrase 2 is the antigen, but it's not entirely clear what it targets to. But this IgG4 antibody targets to that those antigen and somehow leads to this or initiates the inflammatory reaction leading to this disease process. Why IgG4 and not IgG2-1? We do not know that.
Just 2 quick questions, Dr. Satpathy, from our delegates who have been closely following your talk. There were many, but I'm just limiting it to for the time. IgG4 levels or imaging how do you follow them? Will the IgG4 levels go down? And if so, or do you follow by imaging? That's one. The second, relapse. How often are they refractory or relapse, and what do you do then? Sorry, with that we'll close.
Yeah, so at the level of IgG4 as well as the imaging, both should improve over time once they're responsive to steroids. So the disease, as a follow-up, we should follow both IgG4 level as well as the imaging. And with regards to relapse, the second question, maybe I missed the second.
How often do you non-response or relapse? How often, and what do you do then? You've already given steroids, come back or not responded. What is your next step of action?
Well, if they're non-response to steroid, I think we have to consider alternative diagnosis. So I think we're missing these patients who would respond to steroid. They are immunosuppressives. Like as a second line, you can use rituximab, but these patients should respond. If not responding, there is something miss. We're missing a diagnosis here.
I think we'd thank you so much for everything that you have taken up. We have missed many questions, and I apologize to the delegates who sent them. I'd like to thank my co-moderators for participating, the panelists for their expert opinions, Dr. Satpathy for a wonderful talk, and the Gangaram team for the privilege of this session. Thank you.
Thank you.
Thank you, Dr. Manukandan, Dr. Kuru, and Dr. Saeed Hamid. So it was very interesting to learn about this new disease. We would like to move to the next topic now. The next session is on current perspective in diagnosis and management of GERD and hiatus hernia. And for this, I would like to invite our moderators, Dr. Shobna Bhatia and Dr. Saurav Mukhewar. Professor Shobna Bhatia is a consultant gastroenterologist and head of division of neuromotility department of gastroenterology at Sir H.N. Reliance Foundation Hospital. She was former professor and head of gastroenterology at St. G.S. Medical College and KEM Hospital. She was also the former editor of the Indian Journal of Gastroenterology. Dr. Saurav Mukhewar is a consultant at Midas Multispecialty Hospital, Nagpur. He is also an adjunct assistant professor in medicine, Department of Gastroenterology and Hepatology at Cornell University, New York Presbyterian Hospital at New York. So over to you, Dr. Shobna and Dr. Saurav.
Thank you, Ashish. I must thank Anil Arora and his team for this fantastic sessions that we've had. And it is my pleasure to welcome Dr. Pratik Sharma. If I read his full CV, we'll miss our dinner as well as tomorrow's breakfast. Just in short to tell you all that he is currently at Kansas City. He's also on the governing board of the member of American Society of GI Endoscopy and the past president of the International Society of Disease of the Esophagus. Importantly, he's been named as the chair of the American Society for GI Endoscopy Task Force on Artificial Intelligence. We know that GERD is an extremely common problem. It's a disease that's very close to my heart. Many people get heartburn from it, and we'll wait for Pratik to talk to us about this problem. Welcome, Pratik.
Thank you, Shobna and Saurabh. Can you hear me?
Yes, thank you. Yes.
Okay. Hey, Saurabh, good to see you too. How are you?
Good, good, good.
Excellent. Shobna, thank you for the introduction, and Dr. Arora and team. I've been following this for the past few hours, so wonderful sessions, and thank you for having me on. So hopefully I'll get you guys back in time for dinner. So, and just discuss a few issues related to the diagnosis and management of reflux disease. So this is still the current accepted definition of gastroesophageal reflux disease, which is from the Montreal definition. And the way you differentiate minor reflux or minor heartburn to a disease is when these symptoms become troublesome enough for the patient, so the patient seeks care from a physician, or complications, meaning the physician is able to diagnose complications such as erosive esophagitis or esophageal stricture, which then leads it to lend to gastroesophageal reflux disease. Now, this obviously is a global disease, and it started off as a disease of the West, but now you can see that it's spread all over for good or bad. And the population prevalence in India is very similar or quite close to that of the Western population. And several of these Indian studies are from expert panelists who are here today, including Shobna, in which they showed that the prevalence of reflux disease in India is about 10% with a range of 8 to 15%. So something which you will be encountering very, commonly in your clinical practice as well. Has this changed, and what is the population prevalence, at least in the US, in a very recent study? This was published in Gastroenterology last year, in which they took a survey of about 71,000 people in the general population. So these are not patients who are coming to the clinic, but these are surveys which were done through an app over the phone. And when you make the definition according to the Montreal classification, 18% had GERD, which was troublesome. Any reflux, meaning even after eating a meal or a large meal or a fatty meal, happened in close to 45% or half of the US population. So again, telling you that this continues to be a major health issue, and the population prevalence seems to have remained stable over time and is really not decreasing despite all our treatments and diagnostic tools that we are doing. So talking about diagnosis, it's important to recognize that there is no gold standard for making a diagnosis of reflux disease. And that's partly why we struggle in both diagnosis and treatment, is we are not really sure how to do it. But here are certain clues: is when can you use X-ray, for example, and it could be in patients who have esophageal dysphagia or even oropharyngeal dysphagia. Endoscopy is, of course, our go-to test, which as gastroenterologists, it is an extension of our physical examination. So most of the patients do end up getting an upper endoscopy. pH monitoring, manometry, again, all of these are different diagnostic tests which could be used for gastroesophageal reflux disease. Finally, it comes down to the most practical approach. When a patient has symptoms suggestive of GERD, you give them a trial of acid suppressive therapy, and that's how you make the diagnosis. This is more from a very standardized and a practical approach, but how about if you were to look at it from a very scientific approach? This is the Lyon consensus, which looked at what are very objective criteria for gastroesophageal reflux disease. And again, this was by an international working group that Shobna was part of, which looked at if you find LA grade C or D on endoscopy, biopsy-proven Barrett's esophagus, or a peptic stricture, all of these are conclusive evidence that the patient has GERD as the diagnosis. pH impedance has been shown there. PPI use in this situation. Acid exposure time, they said that if the acid exposure time is less than 4%, it is normal. More than 6% is abnormal. Between 4 to 6% is sort of the gray area in which you'll have to take into consideration other patient response issues. And then other adjunctive tests could be utilized as well. So this is a good paper for those of you who want to get into more details about, the diagnostic criteria and the Lyon consensus for gastroesophageal reflux disease. However, when you look at this, we can say that this is probably true for the majority of the patients with gastroesophageal reflux disease, that there is sometimes, or the majority of the times, an unnecessary and inappropriate use of tests and procedures which are conducted in this patient population. So we have to be careful that we don't subject these patients to too many testing, whereas a simple trial may be useful in the majority of the patients. So let's move on to the management strategies. And I think it's important to recognize each one of them because they may cater to a different type of population that you are treating. So let's start off with lifestyle recommendations, which would be for the vast majority, that 44% in the US that have symptoms related to minor issues. So keep in mind food. I think taking a good history is important. Our OPDs are so busy that we are not able to get into this, but if patients have common food triggers and mindful eating, I think that can help the majority of our patients with gastroesophageal reflux symptoms. Sleep, another issue. Think about this when you're talking to your patient is, or do they have that 3-hour gap between their last meal and going to bed? In a typical dinner, if you have it at 10 p.m. after a long day, or 11 p.m. and then you go to bed after an hour, of course, that's going to cause reflux symptoms, even those that have a totally competent lower esophageal sphincter. And then, of course, activity is important. Watching TV, sitting in front and during the lockdown and not exercising, and continuing alcohol and smoking, all risk factors which we could avoid by talking to our patients about these lifestyle changes which can happen. Now let's move on to medical treatment, and then that's where endoscopy, I think, will help guide treatment. This is a patient who's coming in with typical GERD symptoms of heartburn and regurgitation, and these circles point to all areas of erosive esophagitis in this patient population. What do you do in this situation? Well, PPIs are the most effective in healing and relieving symptom in this patient population, as well as improving quality of life. And this is a meta-analysis which shows that right from PPIs to H2 receptor antagonists to placebo, you can see the incremental benefit which is achieved with PPI therapy in this situation. So this is not new news. Everybody knows that. Let's look at the difference between Q-day dosing versus BID dosing. And I think this is something which is relatively of new as well as of importance, is what should we be doing in this patient population, and does BID help? And what this meta-analysis showed that for healing of erosive esophagitis at 8 weeks, twice daily PPI therapy was significantly better than single dose therapy, but not in other situations, including symptom relief. So many times we do that, and I still think it's a reasonable idea to do it. But if you look at the evidence, there really isn't good evidence that twice daily is better than single dose daily of PPI therapy. This is, again, something really important, which is relevant in 2021, is the adverse events and PPI therapy. Nowadays, in our GI clinic, patients are not as concerned whether PPIs are helping them, but they're more concerned about the adverse reactions, including COVID, whether that would put them at a high risk. And this is a whole list of things which have been associated with PPI therapy, not necessarily proven adverse events associated with PPI therapy. Let me show you this meta-analysis, which hopefully has put this to rest. This was published in Gastro a few months ago, looking at close to 200,000 patients in different countries, of looking at the use of PPIs and the risk of COVID infection. And you can see that there is no significant association between the use of PPI therapy along with this association. So I think this is something, hopefully, that we can put this matter to rest and inform not only our colleagues, but also the GPs and the referring physicians, as well as hospitalists, that this really should not be kept in mind while thinking about COVID and gastroesophageal reflux disease. The other thing to remember about adverse events and PPIs are that all these associations are modest at best. So there is an association, for example, of having enteric infections and use of PPIs, but it's a modest association. So you should not stop it just because of that. And you also need to remember that there is publication bias in these studies, as well as no true dose response data which have been shown in this patient population. So some of them are real, the majority not, but again, these are modest associations at best that we need to remember. What else can we do about abnormal reflux burden in this situation? Baclofen can help as an add-on therapy, but it has side effects with it. So be careful if you do decide to use it. It has been shown to be helpful in certain situations, especially in those with increased TLESR relaxation. But remember that pro-motility agents, again, have no FDA approval, but there is poor evidence that they may help in esophageal clearance. In those with poor gastric emptying, yes, these medications could be attempted, especially in a GERD patient who also has concurrent diabetes, for example, or delayed gastric emptying from a post-viral syndrome. You can do an add-on therapy with a pro-motility agent in those specific situations. But in general, they do not help in gastroesophageal reflux disease. A few words about surgery and anti-reflux surgery. And one of the tasks that Anil did give me was to talk about hiatus hernia. So let me share a few videos about what endoscopically a hiatal hernia looks like and how we should recognize them. And I'll pause this as I'm going along. So this is a gradual pullback from a patient with gastroesophageal reflux disease symptoms. And you will see that as I'm coming back from the stomach into the distal esophagus, you will see that there will be a pinch. The first pinch that you will see in this situation is the diaphragmatic pinch. So this is the first pinch which is seen. This is the diaphragmatic pinch. You can see the gastric folds are still coming up, means you've not reached the gastroesophageal junction. So let me play this video a little bit more in detail. And what this will show you is that this patient has about a 3 centimeter hiatal hernia. This is the diaphragmatic impression. So that's where the hiatal hernia starts. These are the top of the gastric folds. This is the gastroesophageal junction. So this extent right from here of where my mouse is, right to this area, this is the extent of the hernia sac. And this is approximately 3 centimeters in this patient. So let's play this forward. This patient also, has evidence in this situation of having significant, esophagitis as well, as I'll come back in this situation. So this is a patient with an endoscopic evidence of a hiatus hernia. This is another situation in which another small hernia is seen. Again, the diaphragmatic impression is right in this situation. You can see the gastric folds coming up as I play this video even further. This patient has a short extent of Barrett's esophagus, and you can see the top of the gastric folds right in this situation and the diaphragmatic pinch in the distance. And you will see that this is the Barrett's segment, which is coming up in this situation. Here's a good example. You can see the top of the gastric folds, the gastroesophageal junction, the diaphragmatic pinch is there. This is a 2 centimeter hiatal hernia in this patient population. So that was the last exam. Here's the final video, again, showing you this evidence of what a hiatal hernia looks like. Again, very important. I'll pause right here. Again, the diaphragmatic pinch in this situation, the top of the gastric folds are right here. A very small 1 centimeter, 2 centimeter hiatus hernia in this situation. Now, these are small hernias, which I've shown you, but if they're large hernias, they can cause volume reflux and lead to massive regurgitation. And that is where anti-reflux surgery may be helpful. This is a randomized controlled trial of looking at PPI therapy versus anti-reflux surgery, 5-year follow-up data. And you can see in terms of overall remission, there really is minor significant difference between PPIs and anti-reflux surgery. You can see that persistence of regurgitation is more common with PPIs, whereas heartburn is more controlled. There is no difference between anti-reflux surgery or with PPI therapy. Remember that bloating as well as gas bloat and dysphagia is much more common in the laparoscopic anti-reflux surgery arm as with PPI. So it's a good alternative. Remember about the side effects as well as the fact that we have about 5 to 10 years, the wrap may start loosening up and the patient may require PPI therapy or even a second procedure after the initial reflux surgery has been done. So what do the guidelines tell us about this? And it says what I've shown you in the data, that it is a treatment option. Doesn't mean everybody needs it. The majority don't need surgery, but this could be an option in this situation. And also remember that if a patient is failing PPI therapy or acid suppressive therapy, surgery is generally not recommended for that patient population. The reason being that those patients do not have reflux as a cause of their symptoms, so it should not be done. Finally, a few words on endoscopic treatment for gastroesophageal reflux disease. This is the esophagus incisionus fundoplication or transoral incisionus fundoplication. This is a gastroesophageal plication in which you can see that this is pulling down on the esophagus, and then a gastroesophageal plication, and the T fasteners are placed in, and a total of 6 to 12 of these fasteners are placed in both anteriorly as well as posteriorly by rotating this device. And in randomized controlled trials compared to PPI therapy, this has been shown to be better than PPIs for reducing regurgitation, but again, in those with a small hiatus hernia only, not in those with the large hiatus hernia. This is again the GERD-X device, which has been used quite a bit in India, and a number of our expert endoscopists all over the country are using this. This is a randomized double-blind RCT by Nagi and Rakesh and the group at AIG, in which they were able to show that at the end of both 6 and 12 months, there was a significant improvement in GERD-related quality of life scores in this endoscopic full thickness plication group as compared to the sham group in this situation. The other is this anti-reflux mucosal ablation, in which what you do is, again, you will see that this is a patient who has a very small Hill grade here, maybe Hill 1 or 2 only. What you do is you inject saline with methylene blue, you raise the gastric cardia in a retroflex position, and then what you do is you create a mucosal ablation by not harming the muscle fibers and causing a bad stricture in this situation, and you do a 270 to 320 degree ablation. And these patients cause scarring of the LES, and at least in studies with 3 months of follow-up, it has been shown to be helpful. But again, longer-term follow-up studies are awaited with these situations as well in this situation. So finally, just to conclude, is that remember that this is a chronic disease. You're not dealing with a one and done in this situation. These patients, the majority of them will come back to you because they have mucosal damage. It leads to dilated intercellular spaces and reduced mucosal impedance in this situation. Once you treat these patients appropriately, your goal is to have better mucosal healing. You can reduce that intercellular spaces where the nerve fibers are, which leads to a reduction in the symptoms of the patient, hopefully reduce the acid exposure time and lead to symptom relief in this patient population. And of course, this can be achieved by a number of therapies, including lifestyle changes, acid suppression with medical therapy, anti-reflux surgery, as well as with endoscopic therapies. So again, Anil and team, thank you for having me on, and Shobna and Saurabh, thank you for moderating this session.
Thank you, Pratik. That was indeed fantastic. And I don't know how you did it in such a short time. It was really fantastic hearing you about GERD. I'll now ask Saurabh to introduce a panel of people. Saurabh, over to you.
Great. Hi, thank you. Thank you, Dr. Arora and the Gangaram team for having me here, and a wonderful conference and a fantastic talk. That was a great overview. We have a very expert panel here today with us. We have Dr. Ramesh Ruprai, who's the past president of ISG. He's a professor and head at Department of Gastroenterology at Fortis Hospital in Jaipur. We have Professor Dr. Bharat Bhushan Gupta. who's the founder and director of the Medieval Gastroenterology Center in Jammu, and a professor and head at Department of Medicine Gastroenterology at the Government College in Jammu. We have Dr. Varun Gupta, who's at the Center of Excellence for Liver and Digestive Care at Patel Hospital in Jalandhar, and Dr. Mayank Agrawal, who is a consultant gastroenterologist from Bareilly, UP here. So thank you all for joining in, and we look forward to the questions from the audience. And Dr. Bhatia, do you want to go ahead with?
So I'll just start off with just a little bit of questioning. So Pratik, you did mention that there wasn't much of an advantage of putting the patient on BID PPIs. So there are two parts to this. What are the situations where you would start to BID PPIs, and in which situation would you add an H2RA at night?
Okay, good questions, Shobna. And Saurabh, you have to keep Shobna under control so she doesn't ask too many tough questions to me, you know. So start with the H2RA, which I think is the easy part, is H2RAs can be added at bedtime in certain patients who are maybe having more nocturnal symptoms rather than daytime symptoms. Again, remember that daytime symptoms are more common in reflux than nighttime symptoms, although we sometimes focus on nighttime symptoms. So you can use it at bedtime. The only issue with that is the issue of tachyphylaxis. So they'll stop acting after a couple of weeks. So if you do that, I tend to tell patients to use it more on a PRN basis. These are mainly patients who may be getting it over the weekend, you know, on a Saturday night after they have a big meal, or you know, that they attend a big party like Anil and have a few nice drinks and everything. So, you know, they may try to do it in that situation. So you can use it on a PRN basis and they will act. BID PPI, the only situation I may consider starting it right off the bat is if you've done an endoscopy and you find grade D erosive esophagitis, grade C erosive esophagitis with a large hiatus hernia, and the patient is having significant symptoms. And this is more of an opinion rather than based on data, because if you look at the data, there really is no difference. But sometimes I feel that if you give them BID and you hope that at least one of that dose will be taken appropriately and the patient will be compliant with, there will be a better response to the therapy in that situation. But also in about 8 to 12 weeks or 2 to 3 months, I'm very fast in also reducing it down to once daily and not keeping them on BID forever. So that's the caveat. So
just a quick last question from me is, so that you don't have too many questions, I'll then leave the house open for Saurabh. So if a patient has persistent symptoms despite proven esophagitis healing, what do you do?
So good. I mean, I think the first thing I usually do is two things. Number one is compliance, and number two is the timing of the medication. So, you know, as I said, it's very important that these medications are taken before the meal rather than with or after the meal. And I think it's very hard for our patients to really understand that. I mean, they just take it whenever they need to do it, and then they claim that the medicine is not working. So it's the PPI is based on the physiology of gastric acid secretion and how they act. I mean, they will not act if it's taken after a meal. So I think it's very important to understand that. So that's one thing, is emphasizing that it's taken before a meal. The second is compliance. And, you know, that's, I mentioned briefly about BID, is that our patients, unfortunately, in this day and age of everything being super fast, people want relief of symptoms right away, today, and not even waiting for a couple of days. And they're very, you know, easy to blame and say that the medicine is not working. So very important to know that they're actually taking it, and they're not, you know, and they're taking it the right way. If you've confirmed that that's still the situation and the patient still has persistence of esophagitis specifically, I would look at other medications. So remember, drug-induced esophagitis is a condition. So a number of medications that we give to our patients, including aspirin, including NSAIDs, including iron, including potassium, which are medications that several of our patients are on, they can cause drug-induced esophagitis, and that can be another situation that you're doing it. You've ruled out all those situations, then I think you can go to BID PPI therapy. Also, at some point, you may want to consider a manometry study that you're not ruling out, to rule out achalasia, because those patients can have persistence of heartburn and some esophagitis, which may be difficult to heal. So just a stepwise approach would be good.
Okay, thank you. Saurabh.
Okay, thank you. Wonderful. All right, so I'll start with Dr. Ramesh Ruprai. We do have a question here. So should we stop PPIs in a cirrhotic patient with ascites who develops spontaneous bacterial peritonitis? Is that your practice?
You are muted, sir.
Usually it is recommended that a cirrhotic, if who develops SPP, then PPIs should be stopped. And but if the symptoms are still persisting, I think we should continue, because symptomatic relief is more important than this association which has been shown. So I think stopping is a good idea, but if the symptoms persist, then we should continue with the treatment.
Yeah. No, I know these are tough clinical challenges.
That's right.
There's no, it's associated, not proven, I suppose. Okay. I'll ask Dr. Bharat Bhushan Gupta, sir. In India, as you are aware, patients are often prescribed PPI prokinetic combination. What is your opinion of using this combination in GERD patients? Do you generally use them, or just sometimes sparingly in select cases?
See, I use it in a select group of patients, particularly diabetics with the diabetic gastroparesis, or patients who are beyond 60 and they have a lot of non-ulcer dyspepsia or delayed gastric symptom related to delayed gastric emptying. But by and large, in my practice, I use PPIs alone.
Yeah. Okay.
So there is one question for Dr. Pratik. The question is, like, we find so many cases of alkaline reflux esophagitis, particularly in patients who have undergone cholecystectomy. What is the advice to these patients? Your management protocol to these patients?
Yeah, no, that's an excellent question. Because some of them are the ones which are difficult to treat. So. And also remember that, bile reflux and symptoms, there's a very poor correlation. So we have to, number one is just remember that. Cholecystectomy by itself, post-cholecystectomy, you can have a number of symptoms post-cholecystectomy. And, so for example, bile acid diarrhea happens in these patients. They get sometimes a lot of gas and bloating post-cholecystectomy as well. So we have to be careful that we have really narrowed it down that this is truly related to reflux, rather than just like, as you mentioned correctly, like non-ulcer dyspepsia or upper abdominal discomfort type of symptoms. Also, another caveat is that a number of patients who have undergone cholecystectomy may not have undergone it for the right reason also. So there may be some symptoms which are just persistent from their initial IBS type of symptoms, or some other symptoms which they underwent. Just because somebody has a gallstone doesn't mean it's causing symptoms. And sometimes I think there is unnecessary cholecystectomies, just like appendectomies, which are being done. So again, I'm not trying to say that the surgeons are bad or anything, but just keep that in mind, because we see these patients after they've undergone surgery, and you assume that the surgery was done for the right reason, but it may not have been done for that, and the patient may just have symptoms. So one question I ask them is, are these the same symptoms you were having prior to your surgery? If it is the same symptom, then it's probably unlikely that it's related to bile reflux or anything else related to that, because these are the same symptoms which are from that. Now, if you've ruled out all of these, I think bile reflux in itself is a very difficult condition to treat. Anti-reflux surgery is usually something which has been shown to reduce, bile reflux. If the PPIs are taken appropriately, that may be a first way to start, because remember that bile comes up into the esophagus along with acid, because bile itself does not have too much volume. The volume is the acid, not the bile. So the bile needs sort of like a vehicle to come into the esophagus, and the vehicle is usually acid. So PPIs are first good line of therapy to start. There was some evidence with bile binding acid resins, so like cholestyramine type of, and non-absorbable bile resin, which initially in phase 2 studies showed that they work, but in phase 3 studies, they really were not helpful. Pro-motility agents, again, knowing the caveats, can be tried in this, patient population as well. And then you'll have to prove it. And the way you would have to prove it is by doing a pH impedance study to show that there is not just bile or non-acidic reflux, but that there is some symptom correlation which is happening as well. So, Dr. Bharat, sorry for the long answer, but it's not a very simple, straightforward that take this pill and it will go away answer.
Well, thank you. So I'll ask the next question to Dr. Varun Gupta. Hi, you there? Yeah.
Hi, Dr.
So Varun, in your clinical practice, see you have a patient with reflux and hiatal hernia. At what threshold do you end up sending them for surgery? Do you have a threshold in terms of the size of the hernia, or how do you evaluate these patients here?
Hi, Dr. Saurabh. Congratulations, Dr. Prateek, for a nice talk. In a practical point of view, more than 90% of the patients will have a very good response with PPIs and prokinetics. I will just like to add sodium alginate and sodium bicarbonate liquid syrups, which are another additional therapy for this erosive esophagitis. But as a medical doctor and not a surgical doctor, if the patient ends up with me, he will have a very good response, and only 1% of the time in a hernia more than 4 to 5 centimeters. So we have patients who have hernias more than around 4 to 5 centimeters. And if they are requiring these therapies for a long time, more than 3 months, and if they are surgically fit, that will be time then when I will ask my surgeon friend to help me with these cases. But more than 95% of the time, I do well with medical therapy alone.
Yeah, agreed. And I'll ask the next question to Dr. Mayank Agrawal, if you could. Hi, Mayank. Yes. So there's a lot of conversation about switching PPIs for general physicians. Often have this question: you're trying one. Is there any role of switching to other PPI? And what about the and what do you think about high dose PPIs that are now being sort of pushed by companies to other gastroenterologists?
I, in my practice, usually start with any easily available PPI. There's not much difference between the different types of PPI. If the patient responds well on, then we can continue it. If there are evidence of esophagitis or else there is marked symptomatic, there's not a symptomatic relief after a single dose PPI, then we might consider adding double dose PPI in some patients. Okay. We also use sometimes baclofen in those patients who are resistant to these symptoms. But PPI don't differ much between different subgroups of the PPI. Patient usually respond well to all.
Great. No, thank you, ma'am. I had another question for Dr. Sharma. So there's a lot of talk about the New England Journal study with Stuart Speckler and colleagues about surgery for refractory heartburn. What is your thought on that?
Yes, thanks. So, Saurabh, thank you for bringing that up. So this is the NEJM study in which patients with quote unquote refractory GERD were randomized to anti-reflux surgery versus, using baclofen in this situation. And it showed that anti-reflux surgery did better. I mean, just stepping back, remember that they had maybe less than 80 patients or so in the study. And I was actually part of the study. And the patient required a lot of vigorous testing. They screened close to 400 patients to get down to these handful of patients in the study. We tried for 2 years to recruit. We couldn't recruit a single patient in the study because partly what these patients required is a run-in with PPIs given appropriately. And majority of these patients, as soon as you gave them as part of a study appropriate PPI therapy, they felt better. So it tells you, number one is refractory reflux or true reflux in the right situation is very, very uncommon. And just as Varun was talking, and we heard from Mayank as well, I mean that, you give them appropriate therapy and these patients will respond to it. In the subgroup that is left, again, yes, I mean, maybe baclofen isn't the best therapy that we have as add-on therapy. If they had chosen, adding either an H2 receptor or, use a PCAB or something like that, these patients could have done better as well. So I'm still reserving judgment, just on surgery for everyone with refractory GERD, just because I don't think that that's the right way. I think Dr. Rai had a question or a comment, please.
Question. I just wanted to ask Pratik, excellent talk. You have not left many questions, but one is that those patients who are awakened in the night because of the acid reflux symptoms, would you be adding PPI the second dose, and how often it is effective?
Yeah, good question. Is yes. So if your patient is on once daily PPI therapy, let's say in the morning, and they're waking up at night, with symptoms, you could add the second dose of PPI before dinner, so 30 minutes before dinner, and see what the response is. If the patient is still symptomatic, then you can consider, the use of a bedtime H2 receptor antagonist right before they go to bed. Always step back and ask them think to yourself why they're having these nighttime regurgitation. And most of these patients are taking a late meal. They're coming home after work at like 8, 9 p.m., then having dinner at 10 or 11 o'clock, and then immediately going to bed, and I think that's always a bad sign that happens. If you remember, our parents, grandparents, everybody after dinner used to go for a nice walk. Part of the reason were these were all lifestyle changes, and they were actually helping our symptoms, because you wait for the food, it helps the gastric emptying, so that by the time you go to bed, you don't have anything in your stomach to have reflux there. So I think the lifestyle changes in that situation may be equally helpful.
Just one more question, that diagnosis of hiatus hernia, is it important that you take out all the air from the stomach before making the diagnosis when you're pulling it up? That would you like to take out all the air, or with the air in the stomach that you do it?
Now, again, Dr. Ramesh, very excellent point. Yeah, I agree. I mean, I think you should try to remove air when you are doing a pullback, and then try to look at the landmarks. What will happen is, if you remove too much air, you may sometimes overcall a hernia by a centimeter or so, which is, again, not a major issue. But, I think we have to be, as endoscopists, need to recognize hiatus hernia, which I think we probably don't do a good job in recognizing that. But your tip is excellent about removing air.
Thank you.
Yeah, Saurabh, can I ask a question to Pratik?
So, well, this is the last session, I guess. I was going to ask you whether we can ask
questions. I have the privilege of asking at least one question, even after knowing that time is up.
Yes.
Pratik, excellent talk as expected. My question is, irrespective of the type of PPI which you give, there is an excellent healing after 8 weeks. What happens after that? Do you monitor it objectively by repeating endoscopy, or you leave it SOS depending upon the base of the type of the symptom? That is question number one. Secondly, is there any role of esophageal manometry in trying to objectively look at the length of the hiatus, which may be subjectively different depending upon whether you have air or how quickly or how slowly you withdraw the scope? There may be subjective component at that. And thirdly, is there any role of adding antacids in patients who have partial relief in the symptoms?
Okay, thanks, Anil. Hopefully I'll remember those 10 questions. So I think the third one was antacids. I think that's the easiest one, which is, I mean, antacids don't have a role for long-term therapy. They're very good for PRN, right? So, I mean, you go to, McDonald's and have a nice, meal with the fries and the large Coke that they want you to take and get obese, So if you have that and you get some symptoms, yes, I mean, antacids are the best therapy. You take antacids, the symptoms are gone right away, and you go to bed and you're fine the next day. So I think for PRN therapy and for those with intermittent mild reflux, I think that's the best therapy. And so that should be continued. Not for long-term chronic therapy. They don't have a role in that situation. The second one was about a hiatus hernia and manometry. As an endoscopist, I mean, I feel that, we do as good a job as with manometry. You may miss small hernias with endoscopy, but those are not the ones who are causing the patient's major symptoms. And, for surgery, those are big hernias, which, again, if you follow these landmarks carefully, you will be able to recognize a 3 centimeter, 4 centimeter, 5 centimeter hernia, which are the ones that need to be fixed. The 1 centimeter hernia does not need to be fixed, which is what you could miss with endoscopy. So I don't think personally that there is really any role for manometry just to make a diagnosis of the hiatus hernia. And your first question was related to monitoring. Monitoring, I mean, patients with grade C or D are the ones that I typically will bring back for a repeat endoscopy to confirm healing of esophagitis. And that's the only patient population. You could argue that in India, you may not even need that unless, Barrett's is a concern. The reason we do it here is because to recognize Barrett's esophagus, which may be obscured with that kind of, grade of esophagitis. Now, Shobna and Saurabh have shown that the prevalence of Barrett's is about 5% in the Indian population, right? So if there are certain risk factors, you may consider bringing those patients back in for a repeat endoscopy, but only for grade C and Ds. The others you don't have to bring, and you can start titrating the therapy to lower doses to maintain their symptoms under control.
So, Pratik, that was a wonderful talk, and I wish to thank my co-chair, Dr. Saurabh Mukherjee, and all the panelists who have asked fantastic questions. And of course, you who've spent some part of your Sunday morning with us. It's late night here. We are ready for dinner, and I'm sure Dr. Anil Arora will take care of the logistics for the dinner tonight.
Yeah,
we'll have an excellent dinner now. And thank you, Anil, for organizing this fantastic academic experience. Thank you.
Yeah, Anil has told me that he'll buy me dinner when I'm at the next ISG conference.
So you are always welcome to come and have dinner at our home. It will be a pleasure and honor.
With the two moderators and all the panelists, we'll all be together.
Yes, of course.
Thank you for including us.
It will be an honor to have you all with us.
Thank you. Thank you, Dr. Shobna. Thank you, Dr. Saurabh, for this session. So we have come to the end of our today's academic feast. So we have learned a lot in these 5 sessions about a lot of things like microbiome, IBD, H. pylori, IgG4, and GERD. So to sum it up, I invite Dr. Piyush Ranjan to give a summary of all what we have learned in 5 to 10 minutes, and then we'll wind up for the day. So Dr. Piyush Ranjan, he's my colleague at Gangaram Hospital. I take over from you.
Well, if you have the stamina to go over all this again, and we had very excellent lectures. We on very important topics, very common topics, and some very exotic topics. We started with the session on gut microbiome, and microbiomes rule the roost. It's the planet and universe of microbiome. Currently, we are having this webinar thanks to a microbiome, the COVID-19, and that is what the microbiomes, how powerful the microbiomes are. Just a reminder how powerful the microbiomes are. Dr. Ajit Sood did a fantastic job in summarizing it up. He started on a philosophical note on the universe within and the universe outside, a beautiful photograph, and took us through the different ways of pathogenesis, the short chain fatty acid, the intestinal mucus layer, and simplified the presentation by giving the outline of different forms of diseases, most importantly IBD and alcoholic hepatitis, which have been treated most commonly with FMT. And hopefully the coming decade, we'll see a lot more on this important topic of use of manipulation of gut microbiome by different means, maybe probiotics and maybe FMT. The second topic was again a very interesting issue on newer molecules in IBD. And Dr. Vineet Ahuja is known to be an authority on this topic. And he started with he started with a philosophical note on Pluto that reminded me of a very beautiful saying that even if Pluto has been excluded as a planet, still it goes about the sun in the same way like it did earlier. So it does not make any difference to Pluto whether it is included as a planet or not. And we all must strive to be like Pluto. So that apart, he emphasized more on what we have available right now in India. He told us about the role of budesonide MMX in the treatment algorithm, where we can use it before using systemic steroids. And then in acute severe ulcerative colitis, we can use cyclosporine more and more in patients who cannot afford drugs. And the good old infliximab still scores better over other kinds of biologicals. And among the newer biologicals, tofacitinib in ulcerative colitis has got a broad application of, and we all know that tofacitinib does not help in Crohn's disease. The third topic of the day was a pulsating debate, a very important topic, H. pylori eradication, whether that helps in functional dyspepsia or not. Again, we learned about the Kyoto Consensus, we learned about the Maastricht 5, we learned about Rome 4, how the definition of functional dyspepsia has undergone a change by treating, we treat these patients prior to, with H. pylori, if H. pylori is positive, before labeling them as functional dyspepsia. There are both pros and cons in treating these patients with with H. pylori eradication and functional dyspepsia. And Dr. Ghoshal emphasized that treating them does not help as a whole, and obviously in settings of gastric prevention of gastric cancer, that was not a topic of the debate. The fourth topic was a very exotic disease, IgG4 related diseases. We have been seeing these diseases more and more. Probably we have been recognizing this disease more and more. Dr. Satpathy did a fantastic job in finishing this vast topic, in covering this vast topic in this limited time. And there were some pertinent questions from the moderators about the role of IgG4 levels. There is a lot of confusion about the sensitivity, specificity, and there's a lot of overlap between different autoimmune conditions, which we already see, autoimmune hepatitis and autoimmune pancreatitis. And the last session on GERD by Dr. Prateek Sharma, it was an excellent talk. He told us one very important study, which he quoted right in the beginning, that PPIs do not have any role in increasing the incidence of COVID. And the clarity of his presentation about the proper use of PPIs would reduce the need of any other intervention, including surgery. And if we do surgery, then we pick up a subset of patients who do not improve. And then there are pitfalls with surgery also. There are long-term issues with surgery. And then obviously endoscopic management of these patients with GERD. I think we have a subsequent lecture in the conference about the endoscopic treatment of GERD. So I think this in brief sums up what we learned today. It was a fantastic discussion in which all the panelists and the chair moderators contributed. Back to you, Ashish.
Thank you, Dr. Piyush. That was an excellent summary of whatever we learned today. So before I hand over back to Dr. Anil Arora for his concluding remarks, I would like to propose a vote of thanks. First, I would like to thank all the speakers who delivered their talk from different parts of the world, all the speakers, all the moderators for conducting the sessions, and all the panelists for giving their comments and questions to our speakers and having an excellent discussion. I would like to thank all the attendees. There have been close to 1,600 registrations, and from both the platforms, YouTube as well as this through Zoom. And we had an excellent attendance today, as we had yesterday. And I would also like to thank our industry partners who had for their generous support. I would like to name them: Micro Labs, Dr. Reddy's, Natco Pharma, 4 divisions of Abbott India, Elnick Life Sciences, Medley Pharmaceuticals, Medtronics, Zydus Cadila, Bountiful Life Sciences, Boston Scientific, Ferring Pharmaceuticals, Fords, and Samath Life Sciences. And last but not least, I would like to thank our event managers, Shefali Singh and her team from Maisha, for this excellent platform and flawless conduction of this webinar. Over to you, Dr. Arora, for your remarks.
Thank you, Ashish. I am extremely thankful to all the delegates, moderators, chairperson, and speakers for making this academic feat very lively and purposeful. I'm sure most of you would agree that rather than going out to DDW or ASLD, we have given you a bonanza of what was the best amongst the different topics of gastroenterology. Thank you so much for joining. I would like to announce also that on the next weekend, that is on 11th and 12th September, we are going to continue the advances in therapeutic and diagnostic endoscopy on consecutive weekend of 11th and 12th. We look forward to see you. Thank you so much. Good night and goodbye. And let's hope we have a fat-free dinner so that we do not end up having significant reflux. With that, I again convey my thanks to all of you for having joined today. Bye-bye.